this webinar. Please bear for another couple of minutes.
Good evening, everyone. I hope you all are safe and healthy. On behalf of IAP Digital team, I, Dr. Himantri Kapil, welcome you all to the COVICON Clinical Rehabilitation New Normal on COVID-19. On behalf of IAP Digital team, I warmly welcome to our resource persons. We are live on IAP India YouTube page. You can subscribe this channel for getting regular updates. During this presentation, if any of you have any question to the speakers, you can put it in the question answer section chat box. Now, I hand over to Ms. Chandini. Thank you.
Thank you, ma'am. Hello, everyone, and a very good evening. Thank you for joining us today on second day of our COVICON 2020. I am Chandini. I will be the IT facilitator or moderator for today's COVICON. I'll be there to assist you throughout the COVICON for any technical help. So before we kick off, let's all stand for our national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you all. IAPWC Bihar has organized this COVICON, which gives us a platform to connect with entire medical professionals under single umbrella. So I'll read out some instructions for a hassle-free COVICON. Sit in a quiet location where you will not be disturbed. Use appropriate equipments. Please post all your doubt and questions in chat window and we'll get back to all of them at the end of the COVICON. Please be on mute while joining the meeting, especially the panelists. On this note, I would like to invite Dr. Smita ma'am, host and host for today's COVICON. Over to you, ma'am. Thank you.
Thank you so much, Chandni. And then we'll move on to the show.
मिलेगी प्रभु की शरण धीरे धीरे मिलेगी प्रभु की शरण धीरे धीरे सदा वेदवाणी सुने कान तेरे सदा वेदवाणी तू कर वेदवाणी का मनन धीरे धीरे तू कर वेदवाणी का मनन धीरे धीरे मिलेगी प्रभु की शरण धीरे धीरे तू कर बंदगी ओ भजन धीरे धीरे भजन धीरे धीरे भजन धीरे धीरे.
Well, we had a very nice warm up. So, COVID-19 is so limited. It cannot cripple love, it cannot shatter hope. You have to figure out your own way to deal with this diagnosis. You learn about yourself what you are made of. This can be extraordinary, and you want to share this. Help others who go through the same thing. You are loved. You are wonderfully made. You are beautiful. You are a masterpiece. God has a great plans for you. COVID-19 has changed our life, often for the better. You learn what's important, you learn to prioritize, and you learn not to waste your time. You tell people you love them. Well, technology is moving at a much faster clip than our laws, isn't it? Can keep up with what would be doing if a plan, I mean, in general, when we talk about if a plane crashes today and 100 people dies, what would we do if it happens again tomorrow and the next day? Now, we would ground air traffic, won't we? Now, we wouldn't live without that. It's being going on every day on our national roadways, highways for at least 40 years, 50 years, 60 years, more than that. Safety applies with equal force to the individual, to the family, to the employer, to the state, the nation, and to international traffic. Now, safety is its widest sense, concern the happiness, contentment, and freedom of mankind. Well, today we have with us my Guru Mata, Dr. Alpana Dongri ma'am. She is CEO Total Rehab Chennai. She is an individual who walks and others follow her footsteps. Madam will be explaining neck tele-rehab as she is an expert in tele-rehab. How are you doing, ma'am? Ma'am?
Hello, Smita.
Yes, ma'am.
Yes, all good.
So, ma'am, shall we proceed?
Sure.
Yes, Alpna ma'am, you can start with your presentation, please.
Hello. Good evening, everyone. First, I would like to congratulate IAPWC Bihar for the initiative they have taken and conducting the first digital national level conference of physiotherapy. It's all the good work of Smita, and I thank Smita and her team for giving me a chance to talk to her, talk to everyone, and put my views here forward. Today I'm going to talk about rehab of the neck. Let me first start sharing my screen. I guess my screen is visible now.
It's loading up, ma'am. Yes, ma'am.
Hello?
We can see your
It,
screen now.
okay. So here we are talking about telerehab. The telerehab, this concept, the term is finding a lot of say, ground these days, thanks to the pandemic. The complete method of delivery therapy is in a new physiotherapy in most of the places in our country, which was becoming more of modality based and prescriptions coming from the other faculties. Now it's going to be non-modality based or less of modality, and it's going to be more of assessment, evaluation, and say judgment by the therapist, planning by the therapist, implementation by the therapist. So it's a good thing. So Telerehab of the Neck, where I'm going to talk to you about the remote consultation and the management of the neck pain. Now, what do we understand by the term telerehab? Telerehab, it's a remote delivery of the rehabilitation therapy and the self-management. The history of telerehab is from 1998 onwards with the advent of the high-speed internet. It uses ICT, that is internet and communication technology, promotes self-care and self-management of the problem by the patient. It's useful for those living in remote places or when travel to the clinic is not feasible. Because in our country, it's like we have a lot of people, especially the women, who don't travel alone. They still need someone to come along with them. And so when that particular facility is not available, we find a lot of women not in a position to receive the help required in time because they don't have anybody to bring them to the facility. So here comes the help of the telerehab. Pandemic conditions like COVID, where people are confined to their homes. Now, what are the tools for telerehab? High-speed internet connection. Most preferably, it should be a broadband connection where the speed of anything between 75 to 100 Mbps is good enough. A smartphone, tab, or a laptop, a proper place in the house which has good illumination, and a video consultation platform which is HIPAA compliant. Most of our, say, the people using here, we the insurance purposes, they will have to use a platform for the HIPAA compliance. So, like we have a lot of softwares available, let us say Practo, MockDoc, and even this thing, Zoom for the healthcare professionals. They have created a platform which is HIPAA compliant. Now, let's come to the main topic of today, that is the tele-assessment. We start with the assessment. Any rehabilitation it's all starts with the assessment, evaluation, planning, and then the implementation. So here, before the consultation, what are the steps to be taken? The first and foremost thing should be send a questionnaire to the patient to collect all the required information. This saves your time. This helps you understand your patient, the problems of the patient. You can be more specific in questioning and planning the evaluation for the patient. Send an instruction video containing how to place the tab or the phone for the consultation, the desired position of the patient during the consultation, instructions for the patient's assistant, because there will be times when you will ask the patient to be performing certain movements. Then an assistant is necessary there to hold the tab of the phone and so that you can clearly see whichever area or whatever the movement you are intending to look into. Desired clothing of the patient. When it comes to neck rehab or the neck tele assessment, the clothing what we normally prefer is For the males, we prefer that they keep the upper body say exposed. For the women, it's more preferable for them to use tank tops. Ask for investigation reports, if any, to be scanned and uploaded in advance. Your patient might be having some lab investigations. Your patient may have some lab investigation reports. Maybe there is an MRI already done. Maybe there are X-rays done. Maybe the patient is having an associated medical condition and is under some medication. So all these things, ask the patient to scan and upload them in advance before you start the consultation. And videos of certain assessment techniques, because here the patient is not face to face. There are certain assessments which we need to be doing where you need to be in direct contact with the patient. So here, what we do is we send them the videos in advance for them to learn how to perform that particular test. And then in front of you, when you have a consultation, the patient performs those tests and you can visualize. Now check the next is check the technology in advance. That means check for the internet connection, check for the functioning of your mic, your camera, check for any sound disturbances. Then keep the patient's phone number to contact in case of any interruption. Now let us say while during the consultation, there is some interruption to the internet services. At the patient end or at your end, you should be having another contact number of the patient to contact the patient, let the patient know that there is a problem and it will be resolved soon. And maintain gender ethics. Here, what we mean is when if at all if a male therapist is consulting a female therapist, then insist on a patient assistant to be there along with the patient, or the therapist should have a female nurse along with him, and then the consultation should go ahead. Now, I spoke to you that we need to send them the questionnaires. Now, there are different questionnaires available, depends on your own comfort or what actually you're wanting to look into your patient. You can decide on which particular questionnaire you want to use. It can be a neck disability index, which is used to see as to how much the pain has affected their person's life. Then patient-specific functional scale. That means here, there are certain functional activities and the patient is supposed to be giving an answer into yes, no, or occasionally. So for example, do you have pain while reading newspaper? So yes, no, or occasionally. This way, this particular score has got some 20 questions. Then the Northwick Park questionnaire assesses the severity of the neck pain and its effect on ADL. Copenhagen Neck Functional Disability Scale to evaluate the disability experienced by the patients due to neck pain. We need to know what is the disability the patient is having, because that then later becomes your outcome measure. Before the outcome measurement, it guides you towards planning the rehabilitation program for the patient. Now, tele-assessment of the neck steps during consultation. You have already sent the questionnaire to the patient. Now the patient fills up the questionnaire, sends it to you. Now the consultation has to start. Now during the consultation, what all things need to be done? Number one, you should be the first one to initiate the talk. So start with greeting the patient, either good morning, good evening, or namaste, whatever you feel like. Then check the connectivity and clarity by asking the subject if they can see and hear you. This builds up a personal rapport, a confidence in the patient that yes, you are going to listen to him or her, and you will understand the problem. A formal introduction to the patient is a must. If you are seeing a patient for the first time, it is necessary for you to introduce yourself as to who are you, your name, and what are you going to do with this particular session from the patient. Now, verbal consent must be taken from the client before the commencement of the assessment. That is, I'm going to consult you with this teleconsultation. I'll be asking you certain questions. I'll be asking you certain, say, medical, or I'll be asking you certain questions. 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 I'll be asking you cer to perform certain movements. So the therapist should be looking at the camera. The patient should also be instructed to look into the camera. This makes an eye contact. It builds up faith. Instead, the patient or internet or audio connection and the session ends prematurely. So it doesn't build up anxiety into the patient. It doesn't, the patient is not worried as to, oh my God, my consultation has stopped or I could not complete, or because there are the neck pain. There are times where the patients have got really bad neck pain and they're looking forward for a help. And when you start a consultation, the patient really wants to convey everything, hoping that you are going to give him a sure shot solution. So they should know that in case the connection goes off in between, not to worry. You will call him on the phone. You will guide how to proceed further. Now, once your consultation starts, the first step is the observation. What do you observe? You observe the resting position of both the shoulders, bilateral shoulder symmetry, bilateral scapular symmetry, because these all things will help you to identify the problematic side, whether it is the right side or the left side. It identifies the possible soft tissue responsible for the deviation in posture, like which particular muscle is responsible, whether seeing the posture, seeing the alignments, you can understand whether there is a tightness of the particular muscles or there's a weakness of a particular muscle. And accordingly, your can be planned. Any muscle wasting needs to be looked into. Any fullness in the supraclavicular foci, and expressions on the patient's face. This is very important. When you look into the patient's face, you know how severe is the problem. You know how comfortable is the patient, and that helps you to go ahead in a more compatible manner, a more friendly manner, and plus it helps you to plan your questions accordingly to make the person relieve the anxiety either because of the pain, number one, number two, or a new method of consultation which the person is exposed to, or number three, it's like, okay, I'm talking to someone who is not going to touch me. How much this person is going to understand, I don't know. So all these things, you can frame your questions accordingly. You can judge what your patient is feeling only when you look into the patient's face. So keep watching on the expressions of the patient. Now, when I spoke to you about alignments and all, what we normally look into when it comes to the neck. So neck, and how do we interpret? So here, I'm just going to let you know. So let us say this particular subject, if you see here, it's like, the right side is depressed. So this right side depression, the inferior angle of the become medial here, whereas this side there, the inferior angle is somewhere here. So this can be because of levator scapular tightness or the rhomboid muscle tightness, or it can be the weakness of the lower fibers of the trapezius or the serratus anterior muscle. See, you can see the bulk here. When you see this particular side, the shape here, you see the shape over here. This is an indication. This shape very clearly indicates hypotonia of the serratus anterior. So definitely it means there is a weakness of the serratus anterior here. Number two, when you see this, here you can see, if you see, this is the T2 level, this is the T7 level. Now, ideally, the complete scapula lies between T2 to T7. Now, if the scapula lies below the T7 and it is below the T2 level, T2 and T7, it is the full scapula is below that region. That means there is a tightness of the pectoralis major or latissimus dorsi, or there is a weakness of the lower fibers of the trapezius. See, we need to know this, how to we observe, and how do we infer out of, what do we infer out of it? That is going to decide as to what are you going to plan for your patient. Now here, if you see this is the acromyoclavicular joint here, and this is the the superior angle of the scapula. The superior angle of the scapula is somewhere here, and this is the acromioclavicular joint. The superior angle of the scapula looks to be higher as compared to the acromioclavicular joint, which means there is a tightness of the levator scapulae muscles. The levator scapulae muscle tightness is later on I'll get into it, but then to just give you a small setup here, tightness of levator scapulae is one of the major causes of multiple neck problems which we come across during this time when there is a work from home norm existing. Here, if you see here, you are seeing this is the acromioclavicular joint. This is the superior angle of the scapula here, which is pushing it up, the trapezius portion, and both of it looks higher as compared to, you can see the acromioclavicular joint here. You see the acromioclavicular joint here. This is much higher up. And when both of them are high, it indicates there is a tightness of the lower fibers of the trapezius and the levator scapulae muscle. See, again here, I'll just add up one more observatory finding. If you see the supraclavicular fossa here, you see the supraclavicular fossa here. This is much deeper as compared to this. You see the sternoclavicular joint here, and here this sternoclavicular joint, you can see the clavicle, which is like, you can see it rotated backwards. Only when it rotates back, you find the fossa becoming deeper. And that happens only when there will be a rounding of the scapula happening. That means the protracted scapula will be giving this thing, a deep supraclavicular fossa. I'm sorry, here the sternum is the clavicle portion, the clavicular part here, it is rotated anteriorly this way in front. So this is much more prominent as compared to here. And because this will happen only when there is a protraction of the shoulder. So again, and you can see this here. I'm talking about levator scapula and trapezius. Both of these muscles, they are basically attached to the cervical spine. They receive the nerve supply from the cervical spine, but they are showing you changes all over here. They are causing the protraction of the shoulder to happen, which will then at times patients do report as supraspinatus tendinitis. That is the impingement syndrome is there, or the patients in very advanced cases do report as frozen shoulders also. But all this thing has an origin only in the neck, nothing to do in the shoulder region. Here, if you see, you will be seeing the glenoid cavity is rotated anteriorly. That means the protracted scapulae. So if you see that, I'm sorry, these lines have moved. Maybe something happened later. This particular line is supposed to be here. Here, the red line is supposed to be here, and then the medial border, the distance from the red line to the medial border of the scapula on either side. Ideally, in an adult, it is supposed to be around 7.5 centimeters. The medial border of the scapula from the midline should be 7.5 centimeters. If it is more than 7.5 centimeters, it is the protraction of the scapulae, which will cause rounded shoulders. And that happens when there is a tightness of the serratus anterior muscle and the pectoralis major muscle on the front side. Now here, if you see this, you see the curve here, and you see the flattening here. This flattening is an indication of tightness. This curve here is an indication of the normal tone. And in the earlier one, when I showed you, this side was more curved, as if the muscle is loose and hanging. That is hypotonia. This is tightness. This is a normal muscle. Now, here, if you see, like, in the retracted shoulders, or if there is a tightness of the rhomboids and the trapezius muscles, there you'll find the shoulders, like, these two scapulae getting closer to each other. The distance between the midline and the medial border of the scapulae will be less than 7.5 centimeters. I'll add up my observation here. I find this type of picture very commonly in ladies here, because see, in our Indian culture, the ladies do, most of the ladies wear saris and they wear blouses which are really tight fitting. So the tight fitting blouses, they pull the scapulae back, and it's over a period of time. Even if you disrobe them, you will be seeing that the particular position of the scapula is maintained, and this deep groove is very clearly seen there. Now with this, then they start getting pains on the front of the, so the costoclavicular joints, they become tender. Costochondritis is a common thing which they come up with. Biceps tendinitis is a common condition with these type of patients, because there is a stretch to the coracoid attachment of the biceps because of the continuous retraction of the shoulder. So these are all consequences of the habits and the dressing what the patients wear. Now, if the entire scapula is elevated, you will, with that particular condition can happen. This is a very, very acute condition which will be happening, and it happens when there is a tightness of the levator scapulae, there is a tightness of the lower fibers of the trapezius and the rhomboids muscle. See, if you can see, if you can appreciate this region and this region, you will be able to see, you can find a good fullness over here. Here it looks to be flat. So this flatness is because of the tightness of the muscle. This fullness is the normal tone of the muscle. So even while observation, if you have a very good observation skills, you can understand as to which muscle, what is the problem, what needs to be done for this particular individual. Now, the next thing, that was all static observations. Now here, you need to be like, you need to also understand what are the different force couples of the neck. That means in the neck, force couples will be exhibited as shoulder symptoms. So you see the upper trapezius and the inferior fibers of the serratus anterior muscle, they form a force couple. They both move together. So if there is a weakness in this, there will be a weakness in this. If there is a tightness here, there will be a tightness here. Middle trapezius and the superior fibers of the serratus anterior, and lower trapezius and the complete serratus anterior as a whole. So while elevating the arm from 0 to 90 degree to 180 degrees through abduction, the different muscle combinations will be working. So here it's like, when you ask the person to be performing the movement, and if at all you find, you normally when we look at the neck, if it is not the shoulder what you are working on, and you presume that the problem, whatever your patient is presenting, is because of the neck, then in that case, what we normally do is we ask the patient to move both the arms simultaneously into abduction. And as they move both the arms into abduction, you'll be comparing the right and the left movement of the scapulae. You will be able to understand as to during which range, which particular segment did not cooperate, and accordingly, you'll be able to plan the management. Now, what are the common neck related problems which we come across, or which the patient will be reporting to you, or the patient comes to you for? Number one is the stiffness in the neck, upper back, hand, and fingers. Symptoms of frozen shoulder. I have recently seen a patient who had, like, he just was not able to move the shoulder at all actively. Passively, there was full range of movement. There was no signs of capsulitis, but actively, this person was not able to move the shoulder, and all the movements which were very specific of capsulitis, like the external rotation being painful, the patient was not able to perform, say, back the over the back activities, taking the hand up on the shoulder, the neck, everything was painful. But on evaluation, it was found there was nothing wrong with the shoulder. The shoulder was perfectly fine. It was the neck which was the problem. Identifying, we could locate that there was a particular, the middle segment of the cervical spine was the problematic region where there was a hypomobility. The lower segments had hypermobility, because of which neuralgia developed, and the patient had this problem. So pain in the shoulder, upper arm or the forearm region, pins and needles, numbness in the hand, fingers, or the lateral part of the arm, painful movements of the neck or the shoulder, weakness in the hand, headache, giddiness, imbalance. increased symptoms of exertional breathing, fatigue, tinnitus. Now here, if you look at this, like, why am I including these things in cervical symptoms? It is like patients, those who have got cervical problems or cervical symptoms, these patients have, the fatigue is sets in earlier for them. These patients, if they are, let us say, if they do some work, they get tired soon. Climbing up the steps, they'll start feeling exertional breathing when it is the neck which is having the symptoms. And there are studies which have noticed, which have documented the patients, those who have a spasm of the cervical muscles, in them the FEV1 by FEV ratios are less than normals. So here, when we are talking about the post-COVID or during the COVID pandemic situations, where we are going to be seeing patients who might have had a COVID infection, whether asymptomatic or symptomatic. Now, if this person has already had a cervical issue existing, now this person, if at all, the person may not have anything else, might be asymptomatic, but then this person will definitely have a fatigue factor which can be contributing more because of the neck, or the person will find difficulty in breathing, which may not, again, the person may not have a COVID infection, but then difficulty in breathing in pre-existing cervical pathology that needs to be really looked out, whether it is the cervical or it is the other thing. Now, who will be your client? During the COVID pandemic, there's an increased incidence in people working from home. So what happens is they have no proper seating arrangements. There are long working hours, unfortunately, and lack of physical activity. So these people, they need your attention. Now, those having online academic sessions, now all schools, even children, like, preschool children, they are also having online classes. I just don't understand. Like, what does it mean for a 3-year-old child to be sitting for 1 hour in front of the system and having a session? But then, yes, that's happening. And there, in our houses, we don't have a special furniture for the child to sit and work with the phone or with the laptop for 1 hour. So improper furniture for the children. I am myself seeing cases like, children. The latest I saw was a child who was somewhere around, say, a fifth standard boy. That means he was 10 years old. And this boy had severe spasm of the neck and complaining of pain in the hand. There was no, the mother says like the child did not fall, there was nothing wrong, but then this complaints of pain in the hand, not able to write down. So these things happen. Increased screen time, lack of physical activity. Next, increased workload for housemakers because there are no house helps available. Post-COVID fatigue is there in the people. Post-COVID low mental health. So these people, most of the times, people with the low mental health, you will find them carrying the neck in the bent position, and that causes the problems for them. What are the evaluation videos we want from the patient? So there are two ways. Number one, either you can ask the patient to perform these movements in front of you, or you can ask the patient to record these videos and send it to you in advance. You can save your time. Flexion extension movements of the neck, side flexion movements to either side, rotation movements to either side. Here, extension and rotation tests should be avoided in new cases because we don't know how much is the cervical degeneration existing with that person. Combined neck movements, shoulder elevation through flexion, shoulder elevation through abduction, cervical percussion test, shoulder depression test, and Addison's test. Now, remote delivery of the therapy. Now, you want to deliver the therapy to the patient. Now, what are the things you're going to look into? Explanation to the patient about how do you start with the delivery of the therapy. You first explain to the patient as to what is the cause of the discomfort based on your assessment and what are the triggering factors. Explain the measures to reduce the symptoms. That means posture correction, ergonomic modification, physical activity. 3, exercise prescription with self-explanatory videos and clear instructions, because this is what your patient is going to follow for the time period what you're going to prescribe for him or her. video to explain the method of releasing trigger points. Yes, these trigger points, there are multiple trigger points which can be released by the patient. You can send small video to the patient based on your assessment as to which muscle needs, the trigger point needs to be released. Explain there how to do, what to do, be very specific, send to the patient. The patient will be able to perform. Provision to maintain the exercise log, because you need to know how much the patient has done, and you can keep monitoring in real time. Equipments like tents, portable ultrasound, cold packs, moist heat packs can be bought or rented by the patient if required. And clear instructions about the precautions, what to expect from the therapy, when to contact the therapist, and when the patient should stop. What are the red flags the patient should look into to stop the therapy and contact you immediately. These things need all to be told to the patient. Now, when you close the consultation, what are the things you need to be doing? Number one, summarize all the key points. Whatever you have seen visualized into the patient, what is your assessment and what will be your plan of management? Clarify any doubts the patient might have. Three, confirm that the patient is happy with the video method of telehealth. Number four, remind the client not to stop his routine medication in case of any comorbidities present like diabetes or hypertension, and say goodbye and close the call, which maintains a good rapport with the patient. So now, what are the advantages of neck telerehab? Number one, immediate solution to the problem from wherever the patient is. The patient can just log in. If you have an app, the patient just logs in through the app, and maybe the earliest consultation can be given. Patient can just start doing, it will help him. Travel cost and time is reduced. Easy to functionally adapt within their own environment. See, when we get the exercises done from the patient in our clinic, because our clinic is equipped, we have the right size of the bed, we have the right arrangement of the exercise area, and we make the patient do that. But then at home, the same replica is not available. The patient finds it difficult to replicate the exercises at home. Here, the functional adaptation to the exercises is better because they are doing the exercises within their own environment. Patient is encouraged to take control of his problem and get involved. So active participation has long-lasting effects. What are the limitations of the tele-rehab for neck pain? Difficult to follow in people with intellectual disability. Not all regions have good internet connectivity. As patient has to be self-driven for therapy, compliance to treatment is compromised in some cases. So what is the take-home message? Number one, cervical disc degeneration and congenital anomalies are asymptomatic for years together. That's the reason why when we have a patient and we tell the patient, see, you have a cervical rib which is there with you from the birth. The first question the patient asks is, मेरे को अभी तक क्यों नहीं दर्द हुआ था, अभी ये 40 साल की उम्र में जाके क्यों दर्द हो रहा है? Yes, because that's the time when now the changes in the muscular performances are happening, and then the symptoms start coming up. Most of the cervical disc herniations are not associated with trauma, unlike the lower back, the lumbar region. Disc herniations are associated with trauma, but cervical disc herniations are not associated with trauma. They are more because of overuse of the shoulder. They are more because of wrong posture of the neck, and they are more because of the big head on your body and wrong habits of nodding the head and moving the head while talking or performing activities. Cervical disc herniations are due to wrong postures, RSI, and overuse of the shoulder. Upper cervical spine instability causes diffuse pain over many segments of the upper back. So your patient complaining of a diffuse pain in the scapular region, which is like, it's not like, ye mera pain hai. It's like, I have pain somewhere here. This is all indicative of upper cervical spine instability, maybe at atlanto-occipital or atlanto-axial junction, or between C1 and C2. Sorry, C2 and C3. Now, lower cervical spine instability, that means C4 downwards, involves shoulder neuralgia. That includes frozen shoulder, epicondylitis, vague rheumatic wrist and shoulder pains the patients will have. So these are like, these are certain things which you need to keep in mind that yes, A cervical pain can have these presentations also. It's not the patient with a cervical pain for a cervical pathology will rarely be the first thing to see. You will mostly find patients coming to you saying, I have pain somewhere here, or I have this thing, or my shoulder, this thing doesn't move, or some pain in this over the back, or my neck is stiff. But pain in the neck per se will be the it's not the first symptom the patient attends to us. So with this message, I would like to close the topic here, and I'll thank your team for giving me a very patient listening. And let me at the end again congratulate you people for doing a wonderful job. Thanks a lot.
Thank you so much, ma'am. You are by our side to guide us always. This pandemic cannot correct fate. It cannot eat away peace. It cannot destroy confidence. It cannot kill friendship. It cannot shut out memories. It cannot silence courage. It cannot reduce eternal life. It cannot quench the spirit. Well, today we have with us a very small girl from, first year student from IGIMS. She has written so sweetly, she has carved a poem on COVID-19. So, we'll be try to play that and enjoy. And we'll try to learn the message she has tried to put on behind this. Chandni, shall we play that?
Sure, ma'am. Give me a minute.
Myself Pragati, first year student of BPT from IGIMS Patna. I am here to recite a poem written by me on COVID-19. Title of my poem is Story During These Difficult Times. Ancestors fought outside their homes, some on the borders, some in prisons. But it's our time to fight by staying at home. It's a virus, that is, a coronavirus. No one knew that we will face a drastic situation, halted by staying at our homes and nothing can do for our nation. We can do a little things to save our lives that are easy for the extroverts, but we can't force the introverts. Use your face mask as your shield. Wash your hands as many times as you can. Sneeze by covering your face. Clean and disinfect frequently touched surface. Unless you protect yourself, you can't protect any other else. The flights are on the ground. Cars parked in the street. Trains do not run. Schools are closed. The children are staying at home. Medical staffs, municipality services, and police services are on the road. We stay on the couches and stay in the room. We sit on our chairs for meeting on Zoom. We stare at the walls and talk to our new friends. That's the web designers, and that is the spiders. We walk on the terrace when the sun rises from east and wait it to set in the west. Traveling places, the windows and the walls sings songs of loneliness, sitting in the balcony and halls. At last, stepping out of house is our choice and urgency too. But come back to your family safely as they need you in these difficult times.
Very well said and very well explained. In the days and weeks ahead, we expect to see the number of cases, the number of death, and the number of affected countries climb every higher. We have with us today Dr. Sailesh Kumar, Associate Professor Medicine, ABVIMS, and Dr. RML Hospital, New Delhi. Sir, will be talking about physician's perspective of COVID-19. Welcome, sir.
Thank
The
you.
show is all yours, sir.
It's thank you to all. Good evening. And first would I like to say thanks to IAPC Bihar to give an opportunity to tell me a webinar on COVID. Now, is it visible? Hello.
No, sir.
No, sir.
So you can see a share screen option in the bottom of your Zoom app.
Yeah.
You can click on that. You see a pop-up which asks which application you would like to share.
Just a minute. Yeah.
Yeah, you can select your PPT from that option. Yeah, it's
Yeah. Now it is visible.
yes, sir. It's visible. Your screen we can see.
This is a structure of COVID-19 in which see spikes on the surface of this virus. So it is a kind of adenovirus that causes infection in our nose, sinuses, upper throat. Most coronavirus aren't dangerous. Coronavirus are important human and animal pathogen. At the end of 2019, a novel coronavirus was identified as the cause of cluster of pneumonia cases in Wuhan, a city in Hubei, province in China. It rapidly spread, means highly contagious, resulting in an epidemic throughout China, followed by an increasing number of cases in other countries throughout the world. In February 2019, WHO named it as COVID-19, which stands for Coronavirus Disease 2019. In early 2020, after December 2019 outbreak in China, WHO identified SARS coronavirus 2. It is a coronavirus type 2. As a new type of coronavirus, the outbreak quickly spreads around the world. There are 7 types of coronavirus, which are pandemic is SARS coronavirus 2. MERS and SARS is also a type of coronavirus, but most coronavirus aren't dangerous. They mainly cause colds or seasonal flu-like feature. This is a structure in which a spike glycoprotein envelop a small membrane protein, and this is surface coronavirus surface. Till now, actually, these data taken since morning. India total 65 lakh 49,375, and active cases is 9 lakh 37,000, and 55 lakh cured, discharged or migrated, and more than 1 lakh death. So India is third largest country which COVID mortality is there. Worldwide, COVID-19 affected more than 3 crore cases. Death is more than 10 lakh, and recovered is more than 2 lakh 61, 2 crore 61 lakh. Now, symptoms of COVID-19. Mainly fever, dry cough. Mainly dry cough is shortness of breath, trouble breathing, fatigue, chills, sometimes be shaking, body aches, headache, sore throat, loss of smell and taste. Mind the loss of smell and taste may is the early feature, before the respiratory symptoms, nausea and diarrhea. These are the differential diagnoses which generally mimic like cold, flu, allergic, and COVID-19. Fever is common in COVID-19. Headache can be present. General ache pains can be present. Fatigue, weakness can be present in COVID. Uh, uh, this is rare in case of cold allergy, but flu and COVID-19 mimics in many features. Extreme exhaustion may be present in COVID-19, stuffy nose, sneezing, sore throat, cough, shortness of breath. Loss of smell and taste is sometimes noted in flu and has been reported in COVID-19. Diarrhea is mainly uh, is seen in COVID-19, but it is occasionally seen in sometimes in children. Higher chances of serious illness if you have one of these health conditions like CKD, COPD, organ transplant, obesity, heart disease like heart failure, CAD, sickle cell anemia, type 2 diabetes. Means those patients, those have this type of problem, they are more prone to COVID-19 infection. And conditions that could lead to severe COVID-19 illness include moderate to severe asthma, disease that affect our blood vessels and blood flow to our brain, cystic fibrosis, high BP, weakened immune response like transplant, HIV, patient mainly on corticosteroid, dementia is also a risk factor, pregnancy, liver disease, damage or scar tissue like pulmonary fibrosis, smoking is one of the risk factors, thalassemia and type 1 diabetes. Coronavirus transmission, because it is a very highly infectious disease, so it spreads mainly from person to person. Most of the time it spreads from the 6% through cough or sneezes. So spray droplets travel up to 5 feet. So if you breathe them in or swallow them, the virus can get into our body. So people who have the virus don't have symptoms, but they can still spread the disease. These are asymptomatic patients. You can also get the virus from touching a surface or object. The virus is on when touching your mouth, nose, and possibly your eyes. Eyes is also sometimes reported. Most virus can live for several hours on surface that they land on. A study showed that SARS coronavirus can last for several hours on barrier type of surfaces. Copper minded, it only remain up to 4 hours. Cardboard up to 24 hours. Plastic or stainless steel 2 to 3 days. That is why it is important to disinfect surface to get rid of the virus. It is very highly contagious, means one person is spread up to 2.5. This is the average. One person can affect 2 to 2.5, and if a person is super spreader, then it can affect 4.7 to 6.6. A normal flu, it affects 1.1 to 2.2. Diagnosis of COVID-19. Diagnosis mainly done by travel history. Previously, it is endemic in China, Iran, Italy. Now it is all over, spread all over the world. CBC, we can see leukopenia, lymphocytopenia, chest X-ray, RT-PCR. RT-PCR sensitivity 30 to 70%. It also depends on where the where we can take from sample. Bronchoalveolar lavage may give up to 90%. Chest CT scan 95% sensitivity. So early diagnosis can be done by chest CT scan. IgM IgG ratio combo test or rapid antigen test. COVID-19 prevention. It is avoid touching, mainly prevented by avoid touching eye, nose, and mouth. Those avoid close contact with people who are sick. Remember that some people without symptoms can spread the virus. Those are asymptomatic patients. Stay at home when you are sick. Cover your cough or sneeze with a tissue, then dispose of it properly. Use a face covering when physical distancing is difficult or when going into closed spaces. Physical distancing should be at least 1 meter, means 3 feet. Clean and disinfect frequently touch objects and surfaces. Perform hand hygiene with soap and water. Use alcohol-based rub. alcohol based up should be at least 6% alcohol, and washing hand up to 20 to 60 seconds based on who recommendation. In India, it is mainly 20 seconds. IPC is mainly for infection prevention and control for healthcare workers and for patients, in which we how we can donning, dropping, and those PPE proper handling. COVID-19 IPC priority rapid identification of suspect case. I mean screening at triage of the healthcare facility, limiting the entry of healthcare workers and visitors with suspected or confirmed coronavirus 19, immediate isolation referral for testing, like group patient be suspected or confirmed COVID-19 separately test or suspected patient for COVID-19, safe clinical management, I mean immediate identification of inpatient healthcare worker with suspected COVID-19 and adherence to IPC practices. A standard and transmission-based precaution mainly hand hygiene, PPE kit, respiratory hygiene, and cough etiquette means don't cough to and fro. I mean here and there. Cleaning and disinfect of devices and environmental services, safe injection practices, and medication storage and handling. This is COVID-19 transmission with precaution. Actually, current WHO guideline says healthcare worker caring for suspected or confirmed COVID-19 patient recommend the use of contact and droplet precautions in a standard to, in addition to a standard precaution. Disposable and dedicated PPE like stethoscope, blood pressure should be used. However, if equipment need to be shared among patients, it should be cleaned with disinfectant, which contains at least 70% alcohol. And ventilation of the patient should be at least 60 liters per minute, and patients should be safe. Those who are suspected COVID-19 should be given single room. Otherwise, if there is lack of space in hospital, then combined together with bed at least 1 meter or 3 feet apart based on WHO recommendation. This one is mainly PP kit, which contains medical mask, eye protector like 3-layer surgical mask, and 95 face shield, gown, gloves. Social distancing. Social distancing also called physical distancing, which are mainly required for keeping a safe space between yourself and other people who are not from your household. In practice, social or physical distancing is stay at least 6 feet or 2 arm length from other people who are not from your household in both indoor and outdoor spaces. Why practices social distancing? It is already I have mentioned. Tips for social distancing: know before you go, prepare for transportation, limit contact and running errands, choose safe social activities, keep distance at event and gathering, stay distance while being active. Quarantine and isolation are two terms generally used in COVID-19. Quarantine who are suspected patient means suspected individuals, and isolation who have positive COVID-19 patients. So quarantine for suspected and isolation for those who have COVID-19 positive. These are some home self quarantine instructions. Stay at home except when getting medical care. Separate yourself from other people in your home. Avoid sharing household items. Wash hand at least for 20 seconds or 2 rounds of happy birthday song. Or sanitizer having 60 to 70% alcohol. Call ahead before visiting your doctor. Monitor your symptoms. Wear a face mask with the colored side facing outward. Cover your cough and sneezes with tissue. Till now, there is research going on coronavirus vaccine, but at least approx 100 coronavirus vaccine on phase 3 trial. COVID-19 treatment mainly by antihistaminic analgesic on Actually, COVID-19 categorized on four types: asymptomatic patient, mild, moderate, severe. These are mainly by saturation, SpO2 saturation, and respiratory rate. So mild cases can be treated at home with supportive treatment, antihistaminic, analgesic. Moderate cases uh, to corona dedicated hospital where we can give hydroxychloroquine, even favipiravir and uh, remdesivir. Severe cases may oseltamivir, ropinavir, ritonavir, or hydroxychloroquine may be given. These are flow diagram for treatment protocol of COVID-19. In this, mainly, if a patient have COVID-19, we can go for investigation like CBC, basal metabolic panel, CRP, ferritin, LDH, fibrinogen, TROPI, BNP, hepatitis B surface antigen, hepatitis B core antibody, hepatitis B surface antibody, imaging like chest X-ray, ECG, pulse oximetry. And based on this, if a patient is having mild symptoms, then patient can be treated at home. If moderate, we can give remdesivir or plasma therapy. For severe patient, we can give dexamethasone, steroid, or methylprednisolone. Uh, Now there is some role of ivermectin is also recommended, but till the approval is not for till now approval of ivermectin is not recommended in treatment protocol of COVID-19. We all know India has applied four phases of lockdown for treatment purposes of COVID-19. In protocol of India is RT-PCR, and point of care molecular diagnostic tests are being for the diagnosis of the disease in country, rapid antigen test and also antibody test, pool testing, and there now at present there is no vaccine for SARS coronavirus 2. How India is treating COVID-19 mainly by mild cases to moderate cases by hydroxychloroquine or favipiravir dose already in that flow diagram. Investigational therapy also is there. Remdesivir is already dose is already mentioned. And off-level convalescent plasma, I mean plasma therapy for patient with moderate COVID-19, not improving oxygen requirement despite the use of steroids and tocilizumab. We also check patient IL-6 levels. If IL-6 level elevated and this remdesivir is convalescent plasma is given and patient not improving, then we can give tocilizumab. Corticosteroids is mainly methylprednisolone and dexamethasone, which are used in COVID-19, and low molecular weight heparin or enoxaparin to prevent blood clots and thrombogenic reactions. So now conclusion, across of the COVID-19, India is an immensely populated country, hence the country need to take watchful steps. The use of masks, frequent hand sanitizer, proper sanitation, physical distancing, avoid crowd, and healthy lifestyle must be the new normal life in India. To contain the spread, foremost emphasis is essential on the rigorous testing. Rigorous testing, necessary equipments like PPE, ventilator, research and development activities. Regular counseling of people are also imperative to reduce the mental stress. It is vital to come up with a sustained advancement of policies after the COVID-19 experience to deal with such unprecedented circumstances with a holistic approach. One has to win this war quite intelligently with the public support and alertness. In a way, COVID-19 has taught people the highest discipline of life. So my presentation is over. If you have any question, then you can ask. Thank you.
Well, thank you so much, sir, for such an informative session. The fundamentals of public health have proven successful to contaminant of the COVID-19. Some of these measures, especially mentioning activating emergency mechanisms, taking it seriously from the start, reporting governmental officials to tackling the virus, testing, quarantine, case and contact, finding it or tracking, mobilizing the population to protect themselves, and practicing basic hygiene. Today we have with us Dr. Ishani Hanspal, Faculty, Department of Community Medicine, Sir Balaji Medical College and Hospital, Chennai, consultant physician and Total Rehab Chennai. She will be taking up rehab for lifestyle diseases. Hello, Dr. Ishani. How are you
Hello,
doing?
Dr. Smita. I'm good. How are you?
Very fine. So grown up girl, huh?
I know, we go back a long time.
Yeah, I saw you last when you were in seventh, right? If I'm not
Yes,
mistaken.
yes.
So, shall we start?
Sure, sure. All right. I would first like to begin by thanking IAPWC and Dr. Smita for giving me an opportunity to share my thoughts. As from the public health point of view, and more importantly, as a preventive medicine physician, my views on COVID is more directed towards the post-COVID situation where a lot of health challenges are awaiting us. So I'm going to talk about lifestyle diseases in view of rehabilitation. When coronavirus hit the world, we were still in the middle of tackling an ongoing epidemic. This was the epidemic of chronic diseases. Chronic diseases have been on and rise for over a decade now. They continue to be the leading cause of death for the past 10 years. The steps that we have taken to tackle the COVID-19 pandemic, such like lockdown, stay at home, isolation, quarantine, social distancing, work from home, all these measures, if you notice, has a common trend to these. They all have an unintentional after effect of increased physical inactivity and increased sedentariness. This is a risk factor for chronic diseases, for lifestyle diseases. Taking a deeper look into the consequences of lockdown, it caused an increased physical inactivity, increased sedentariness, being at home, working from home, unhealthy diet choices, craving for junk. Take the situation of working from home. Currently, a lot of people are working from home. What happens in such a situation? The person is glued to his chair for long hours, stuck on the chair, looking at the computer screen. Meetings are happening at home. The meeting hours, the working hours have become longer. There is an increased stress, increased anxiety. There is inadequate sleep because of all this, and a lot of fatigue. What are all of these? All of these are increased risk factors for lifestyle diseases. Take a look at obesity. An obese person is at risk of a lot of diseases, mainly 4 important lifestyle diseases: the cardiovascular disease, diabetes, chronic respiratory disease, and also some kinds of cancers. Lifestyle diseases are also known as chronic diseases and also called non-communicable diseases. 4 diseases in particular: cardiovascular diseases, chronic diseases, cancers, and diabetes, all of which an obese person is at risk for, are together called fatal 4 because they are responsible for 70% of deaths globally. Post-COVID, there is an impending threat of a bigger chronic disease pandemic which is just waiting for us. A WHO rapid survey has already found that there is a 5% rise in diabetes ever since COVID has started. I only wonder what are the figures for the other lifestyle diseases. They're going to be high. Here shown in the figure are some prevalent statistics for India of lifestyle diseases. If you notice, no age group is spared from lifestyle disease. Significantly, each age group is affected by lifestyle diseases. And this is only going to increase because over the past few months in the COVID care, the routine healthcare services were disrupted. The people with chronic diseases like diabetes and hypertension, they did not receive the routine follow-up. Routine cares were not done. And as we already saw the effect of lockdown, there is a potential threat for further increase in the number of the already abundant chronic disease. We need to act now. This is a common model for in relation to lifestyle diseases, which is used by the WHO. It shows that the underlying factors which is the current situation prevalent now, such as aging, a lot of elderlies have increased, urbanization, rising income, and a disturbed work-life balance, all of this predispose to unhealthy lifestyle choices. And lack of awareness to chronic diseases is more of a policy issue. All these factors lead to modifiable risk factors. They are modifiable because they are choices. They are behavior choices that we make, like a physical inactivity, unhealthy diet, harmful alcohol use, consumption of tobacco. These are rather behavioral choices that we make and can be modified. These in turn lead to changes in the metabolism, such as overweight, high BP, elevated blood sugars, and elevated lipids. All of these translate to the major communicable diseases of diabetes, cancer, chronic respiratory diseases, and cardiovascular diseases. What we need is something which is going to tackle this particular area, the modifiable area. This is what is going to save us from the impending threat of chronic disease epidemic, which is going to come back in a bigger form. I propose a concept called prehabilitation for lifestyle diseases. What is prehabilitation? Prehabilitation is a concept which involves interventions aimed at improving the patient's health before an anticipated or an upcoming stress, which could be physiologic or psychologic, so that the person is able to withstand this stress better. For example, before a planned surgery, fitness of that particular patient is improved so that post-operative recovery is faster and much better. Comparing prehabilitation with rehabilitation in terms of disease, rehabilitation sets in when the disease has already occurred to restore the lost functions and skills due to the disease. On the other hand, prehabilitation comes into play before the disease actually happens. It aims at preserving and strengthening the healthy body function. The aim of prehabilitation is to regain the maximum self-sufficiency, while prehabilitation aims to retain a disease-free state. Looking into the evolution of prehabilitation, prehabilitation is rather a little older concept. The first mention of prehabilitation dates back to 1946, where an article was published in the BMJ. The paper describes an experiment carried out in centers called prehabilitation centers, where the army men were subjected. In this experiment, there was good food, good hygiene, as well as controlled physical exercise and education given to the army men. And at the end, for a period of 2 months, at the end of which 85% of these 12,000 soldiers who participated in the experiment had an increased health rating. This particular paper also says that the health effects that were attained, the physiologic as well as the health improvements that were seen, were rather easily achievable. And it was also reported that the soldiers said that their outlook on life also improved. I propose to extrapolate these learnings into prehabilitation for lifestyle diseases. Coming to the evolution, In 1980s, lifestyle prehabilitation was seen as a means of injury prevention in athletes by the sports medicine community. Preoperative rehabilitation came in 1990s with the aim of improving surgical outcome. After 2010, emerged the cancer prehabilitation. The aim was to prepare the patient to endure the tough cancer treatment and to improve the long-term health of this patient with cancer. I now propose lifestyle disease prehabilitation, which is the need of the hour. Why do we need it? Why is this lifestyle disease prehabilitation relevant to us? It is because the healthcare facilities and the healthcare delivery system is already maxed out. It is currently overburdened with care for COVID. The demographic trends are changing. The world is growing older. Longevity has increased thanks to the improvements in healthcare. But we are going to soon have a proportionately more number of elderly patients, which translates to more number of people with chronic diseases. The economic burden due to lifestyle diseases is also going to increase. Currently, there are projections which are made, which say that the global economic burden due to diabetes is going to increase from the current 1.3 billion, which is already too much, to 2.5 trillion by the year 2030. In India, it is estimated that the direct burden due to cardiovascular diseases is approximately 200 billion rupees. In our country, where the GDP towards healthcare is only about 1.5%, a lot of people are forced to pay out of pocket for their healthcare. And chronic disease, the nature of chronic diseases is such that there is repeated encounters with the healthcare facility and repeated out-of-pocket expenditure, which predisposes the people to catastrophic health expenditures and distress borrowing. Post-COVID, such economic and social impact of lifestyle diseases, chronic diseases, is only going to worsen. We need to act now, and lifestyle disease prehabilitation is only going to do that. Stages of lifestyle disease prehab. Stage 1 is to maintain and retain a healthy state. It is to avoid the emergence of risk factors itself in an otherwise healthy person. Stage 2 is to put a check on the risk factors to progressing to a disease state. It is to check the risk factors that are present to culminate into metabolic disturbances so that disease does not occur. Stage 3 is to put a check on disease progression and rather also focus on causing a reversal to reverse the changes of the disease and also to prevent complications of such a disease. The implementation of prehabilitation for lifestyle diseases requires the expertise and input from a range of professionals. The multidisciplinary prehabilitation team ranges from medical, allied health sciences, as well as non-clinical personnel. Shown over here is a team that multidisciplinary team to tackle the common risk factors for the fatal 4 chronic diseases. In the team are physiotherapists, exercise scientists, and trainers for the exercise intervention, nutritionists, dietitian for the nutrition component, harmful use of alcohol and smoking to be dealt by a counselor, psychiatrist, or a psychologist, and the mental health and well-being taken care by a psychologist as well as a psychiatrist. For an effective rehabilitation, it is important that the patient be placed at the center of all these interventions. Now, how to implement prehab? The implementation of lifestyle disease prehabilitation has 3 components: evaluation, assessment, and intervention. In evaluation, first, screening or risk factor assessment is done to stratify the risk and to plan the care. In lifestyle disease prehabilitation, the patient is seen as a whole person and not only the disease and not only the illness. The whole focus is on the patient as a whole. And the HNA, which is the Holistic Needs Assessment, does that. What is HNA? HNA is a discussion that happens between the healthcare provider and the patient about the physical, psychological, as well as spiritual and social needs of this particular patient. Assessment is done by the particular team member of the multidisciplinary team as directed by the screening. A more detailed approach is taken, which includes history taking, physical examination, clinical lab tests might be commissioned. Then judgment is done to determine what sort of intervention needs to be done. Assessment is also done to determine effectiveness of intervention. Interventions in lifestyle disease rehabilitation are customized for each patient. As it is already done in cancer prehab, a similar approach for lifestyle disease rehab can be applied where the three categories of interventions are available, like universal, targeted, and specialist. Explaining this with the help of an example of physical inactivity and unhealthy diet options as risk factors, universal interventions will be adhering to the recommended WHO recommended guidelines for physical activity, like having this particular person to adhere to 150 minutes of physical activity, at least 150 minutes for a week, and follow a healthy diet plan. On the other hand, a targeted intervention would be for a person who has a risk factor, a BMI is increased or has a reduced physical inactivity, where a supervised high intensity training in terms of exercise may be given to such a person. A specialist intervention is directed to a person whose lab tests maybe diagnose a particular metabolic imbalance, such as maybe the lipids are elevated. So a specialist intervention is required in such a person. This is a tier approach for lifestyle disease rehabilitation that I have described. Now, unhealthy behaviors and lifestyle diseases often cluster in the same individual. This is described as a risk multiplier effect. In such people, multimodal interventions, giving a number of interventions at the same time and simultaneously results in a faster result because of the synergistic effect. But in certain conditions, a sequential intervention may be required. Back-to-back interventions will give an additive effect. This is a choice which is made because upon assessment evaluation. Shown here is a sample plan to tackle the 4 common risk factors that happen due to lifestyle diseases and which are also the consequences of the lockdown right now. Physical training to improve the physical activity, tackle unhealthy weight gain, and improve the muscle strength. Nutritional interventions to provide a healthy diet option, address micronutrient deficiencies, which are called hidden hunger, and the smoking and alcohol risk factors. Psychological interventions to address anxiety and stress. All these, most of the interventions for lifestyle diseases require a behavior change, which requires a great deal of motivation. Techniques to optimize the mental readiness and increase motivation of the same requires psychological intervention. Medical optimization is needed where prescriptions are required, where drug and dosage adjustments are required, also for monitoring vital signs. Mode of delivery of rehab is best face-to-face, since there are better results when it is done under supervision, as the motivation level of the patient remains high. But given the current situation, telemedicine or tele-prehabilitation is the way ahead. And the advantage to it is it can be more flexible, and cost factor is also on the better side. But the concern over here would be to monitor patient adherence. What we do is PPP, called the Personal Prehab Plan, which is tailored and personalized approach to lifestyle prehab. The prehab methods vary from patient to patient, because two people with the same diagnosis, 2 obese people may not be same. One may have hypothyroidism and asthma, while the other may have diabetes and arthritis. So the type of intervention which is given to these two people are going to be completely different. When physical activity is advised to a person with arthritis, the pain component has to be borne in the mind, and such modifications have to be made. Patient has an active role in rehabilitation, and he is also given the opportunity to contribute in managing his own health. Successful of lifestyle disease rehabilitation depends a lot on the motivation and capabilities of the patient. Coming to the challenges of lifestyle disease rehabilitation. Despite all the expected benefits, it is still not widely used and implemented. There are a lot of implementational challenges because it requires the cross-sectorial coordination and collaboration. Research and in terms of randomized controlled trials is still scarce in terms of lifestyle disease rehabilitation. And as with any sort of preventive measures, motivating the users to actively participate is a little difficult to achieve. To conclude, I would like to say that lifestyle disease paradigm is a promising paradigm. It is based on sound theoretical principles, and the evidence that we have so far is quite encouraging. In the near future, I'm sure rehabilitation will play a significant role in the management of lifestyle diseases. As Benjamin Franklin said, an ounce of prevention is worth a pound of care. And this is definitely what we need to do in future. Thank you. If there are any questions, please let me know.
Thank you so much, Doc. It was very well explained. Well, you have to figure out your own ways to deal with this diagnosis. You learn about yourself, what you are made of. This can be extraordinary, and you want to share this, help others who go through the same thing. We have with us Dr. Sadaf Faisal, Senior Resident, Ram Manohar Lohia Hospital, New Delhi. He will be highlighting on management of COVID-19. He has not been to his home since months. So as he was working for COVID patients, he was giving his service, he was rendering his service there. So a big round of applause for you, sir. Hello, sir. How are you doing? Over to you, sir.
Hi, Dr. Smita. I'm fine. How are you?
Very
First,
fine.
let me be very thank you, and I'm very thankful to you as well as AIPWC for considering me
It's
worthy
not,
enough to come
it's not
and
AIP.
share my experience. It's
Yeah.
AIPWC.
No. It's IAPWC, Indian Association of Physical.
IAPWC.
Yes,
I'm
sir.
very thankful to you, and let me introduce to you everyone. Myself, Dr. Faisal. I'm a postgraduate in anesthesiology and critical care from CMC Ludhiana. Right now, I'm working in RML, and it was one of the first COVID centers of the country. So I've been seeing patients, how we are managing patients, COVID patients, right from its infancy to the very advanced stage, and a lot of changes that have taken place. Right, initially we used to give like hydroxychloroquine, chloroquine, to right now drugs like remdesivir, plasma therapy. In due course of time, after every fortnight, every month, it has gone a lot of changes. So it's been a tiring time, but as well a very experienced past 6 months. So let me start in a nutshell. I've been assigned a stipulated time. So basically, I'll be dealing with the management of COVID-19. And I've been watching this program, and I've seen a lot of things have been covered by my colleague and my batchmate, my dear friend, Dr. Sailesh Kumar. But let me brush out. So first of all, what exactly is coronavirus? Coronavirus, the disease that has totally, taken this world by storm. It's a pandemic. It has spared no one on the basis of your race, whether whites or the Negroes, continent-wise, whether the Americans, the Australians, the Indians, throughout the human race. This pandemic has affected each and every one of us, and we are all paying a very heavy price for the last 6 months. So basically, in a nutshell, what is coronavirus? It's an RNA beta coronavirus. It's an enveloped virus, and it's known to cause a disease in animals and humans. And it spreads mainly by droplet infection, as well as it is fomite borne. And the incubation period is ranges somewhere on the lower side it is 2 days, on the higher sides 15 days. In the Indian scenario, it's somewhere around 5 to 7 days. And the period of infectivity is like before the onset, 2 days before the onset of symptoms, and it lasts for up to 8 days after that. So that's in a nutshell, in a very brief, what exactly is coronavirus. Now, before coming to the management, two definitions that have been given by the WHO, the World Health Organization, we have to be very clear about it. One, what is ILI, or influenza-like illness? And the other, what is SARI, severe acute respiratory illness? So in both, you have a high degree of temperature. The fever, the temperature ranges above 38 degrees centigrades. The patient presents with cough, and it lasts for, say, about 10 days. But if influenza-like illness, if it becomes a little more severe, where the patient requires hospitalization, then in that case, we term it as a SARI, or severe acute respiratory illness. Now, I will not be focusing on the main symptoms. The coronavirus, it presents with a myriad of symptoms. We all know, okay, you patients have fever, cough, cold, body ache, but what are the lesser known symptoms that this virus on infecting human being, what it causes? So my focus is on the lesser known. Okay, everyone knows if you are infected, you might be asymptomatic, you might have fever, you might have cough, you might have body ache, but what are the other symptoms that this deadly disease, this COVID-19 uh, manifests in human beings? There will be fatigue, there will be shortness of breath, there might be some expectorations, there might be myalgia, there might be rhinorrhea. Patient might present with simply sore throat, or there might be a chance where patient may not have any symptoms but just diarrhea, or just the patient may be complaining that he or she is not able to smell properly, difficulty in smelling, or a taste sensation might be impaired. Or in the elderly and the immunocompromised, the patient might simply complain of fatigue, may not be able to concentrate on what exactly it's long-term concentration may be lost. There may be reduced alertness. Patient might become lethargic. The mobility might be reduced. The patient may not be, like, say, willing to eat. His or her appetite may be reduced. Might be delirious. Some psychiatric disorder. Just delirious. No fever, nothing. Just a feature of delirium. An elderly patient, say on steroids, may just come to you with features of delirium. Might have no fever or nothing like that. So it's very dicey, and you have to have a very high index of suspicion in order to suspect. You must have both the antenna up whenever a patient comes with an atypical symptoms. Typical symptoms, yes, it's fairly easy to diagnose, but what is challenging is the odd cases where the patient presents with no features, no classical features. The patient may present with simply one symptom, loss of sense of smell for the last, say, 7 to 10 days, and you should have a high index of suspicion. So coming to the main portion that I have been assigned, time is limited. The diagnosis, how do we diagnose? Now we have RT-PCR as well as the TrueNAT. The RT-PCR stands for real-time polymerase chain reaction. So what exactly do we do? Here we detect the RNA of the COVID-19, and a patient comes. So from where do we take the samples? The sample is taken from the throat and the nasal swab. From the nasal swab and the throat swab, we take the sample for RT-PCR, and it is the most confirmatory test. Ideally, it's done in the laboratory. Not ideally, it is done in the laboratory, and you take around 24 hours to 36 hours in order to give the results. So the RT-PCR, in a nutshell, is the most confirmatory test that we have right now currently available, which takes about 24 hours time to diagnose. And this is the most confirmatory test. Then the other test is the rapid antigen test. Here we detect the COVID antigen. It's also known as standard Q COVID-19 antigen test. Compared to the RT-PCR, it is fast, it gives rapid results. But there's a big but here. If it is positive, then we may consider the patient as positive. But if it is negative, it cannot be ruled out the patient is not having COVID. So in that case, we have to go in for an RT-PCR if we suspect that the patient is have a strong suspect of COVID-19. So two tests, RT-PCR, which is confirmatory. The swab is taken from the nose and the throat. It takes 24 hours. It is 100% confirmatory if you are positive with that. And the other is the rapid antigen test. It is fast. It takes lesser time. But if a patient we are suspecting to be COVID, and if his or her test comes to be negative, then in that case we have to go further. We have, in a nutshell, we have to ultimately rely on RT-PCR to be fair enough to have a diagnosis that this patient is suffering from this disease. Now, which test should be done and where? Now, as I have told you, the rapid antigen test, it's basically for surveillance. India being an overwhelming country, all symptomatic influenza-like illness. We have seen that patient presenting with fever, cough for at least 7 to 10 days, we have to go for rapid antigen test. Then there are all the asymptomatic direct household contacts of high risk contacts. Suppose me being an anesthesiologist and critical care expert working as a consultant in RML, we at a stretch 10-bed ICU. It's full of COVID positive patients. If I come at home, ideally I stayed in a hotel during my COVID posting, but there are times when I'm posted in OT and it's an emergency case. And after the case is, we do the case after taking all due precautions. We wear the PP kit, but after operating, we get to know that this patient, because of the shortage of time, because of emergency, we have taken this case on an emergency basis without verifying his COVID results. Comes out to be a COVID positive patients. Then in that case, my entire family, I'm putting them at risk. So for those patients, we go in for this test. Then all asymptomatic high-risk individuals working in these COVID areas. Then the next test, the RT-PCR, polymerase chain reaction. For whom do we do? All SARI patients. SARI, as I've earlier told, it's nothing but severe acute respiratory illness. Patient presenting with fever, cough for at least 10 days, requiring hospitalization. All then other cases, all symptomatic presenting to the healthcare centers, symptomatic confirmed cases, then healthcare workers and frontline workers, then symptomatic INA cases among migrants. Yes, migrants, there have been a tremendous amount of migrant laborers who had migrated from the metros, particularly from Delhi, Mumbai to remote areas of Bihar and Uttar Pradesh. Then pregnancy we know is an immunocompromised state, and those particularly who are nearing labor, so they have to be, we have to do this test. And the last point that I just mentioned you, that any cases that we have to operate, so we have to take an RT-PCR and then only we can take those cases. It's only when we are shortage of time, where we are in dire, we have to take the patients immediately. It's a life-saving process, like fetal distress. A patient comes from remote area, being operated for cesarean section. She may not be a noted patient. For that matter, a stab injury or gunshot injury, where there is a tremendous loss of blood, where we cannot wait for the result. We cannot afford, the time doesn't permit for an RT-PCR to be done. So those patients we take without the RT-PCR test, but a routine elective surgery for lab coli, for example, or we have sufficient time. Suppose intestinal obstruction, where we can get 1 day time or 2 days time. So ideally, we take an RT-PCR. If it is negative, then we proceed with that test. The emergency cases, they are expected. In that case, we take all the precautions. We put our life at risk. We wear the PP kit, everything and all, and we take the necessary precautions. So these are the places where we have to undergo both the tests. I myself had gone RT-PCR for 5 times, 3 times. I was exposed Once I was exposed to a patient who presented with an RT-PCR negative one day earlier, and I was working in a non-COVID area. The patient was a 70-year-old gentleman. He came with an RT-PCR negative. I was posted in non-COVID ICU. There's a protocol in RML where we have the COVID ICU and a non-COVID ICU. In a non-COVID ICU, we take those patients who are RT-PCR negative, I mean, whose reports are like, we presume that they are non-COVID, and we ask for an RT-PCR test. So this particular elderly gentleman, he was RT-PCR negative one day earlier. So he came, and this elderly gentleman happened to be the father of one of my PG students. So we had full sympathy for him. But the patient was extremely sick. He came with a saturation of around 60 to 70%. And his chest was tremendously bad. So what we have to do, initially we tried to manage with a non-invasive ventilator, but it didn't work out. And I was the one who was just putting on an N95 and a surgical mask because it was supposed to be a post-op non-COVID patient. I had to intubate this patient, and the patient was very sick. He had lots of comorbidity. He had diabetic, he had chronic kidney disease. He was hypertensive for the last 10 years, and he was not maintaining saturation. Unfortunately, after 3 or 4 hours, he underwent cardiac arrest. We did CPR. We tried our level best. He went into septic shock. We started NORAD. We tried all our level best. We intubated the patient, but unfortunately, we cannot save this patient. We couldn't save this patient. And after that, a high index of suspicion was pointed. This patient might be COVID negative yesterday, but he is presenting the classical features of corona. So why not get his sample examined? We sent this sample, and it came out to be RT-PCR positive. So we were all in a state of shock. Exactly didn't know what to do, but we were given some quarantine, and we all praying to the Almighty that let's see nothing happens to us. But God willingly, our test came negative after 10 days of quarantine. So this is one of the experience where a patient might be negative one day earlier, can be developed positive, but because I have said he happened to be a father of my PG, so we had given him the benefit of doubt. But we have to have a very high index of suspicion. So one thing we need to be very clear where we need to do a rapid antigen test, where we need to do an RT-PCR. Now, the severity, the treatment based on, we cannot like, it's not preparing a cup of tea, you put two, or preparing a cup of early morning garma gram coffee. So your treatment depends on the type of patients. We broadly divide these patients into 4 categories. Please excuse me. We broadly divide this patient into 4 categories. One is the asymptomatic patients, nothing to be done. The patient doesn't present with any symptoms. Might be COVID, yes, it's a fact. In fact, quite a good number of Indians, we Indians are have a very strong immunity. Majority of them might have COVID, but they're not aware of that. Okay, as they might be asymptomatic. Then the other 3 are the mild, moderate, and the severe. Now, what distinguishes with among the 3, the mild, the moderate, and the severe? In the mild cases, there will be respiratory symptoms. Patient might be having cough, but there won't be any evidence of breathlessness, or the patient will not be having hypoxia. I mean, in short, the patient will be maintaining saturation. The only symptoms, mild cough. Then the moderate symptoms. Yes, here the patient will be presenting with respiratory problems, like there will be shortness of breath, breathing difficulties. His respiratory rate might be on the high side, tachypnea. Respiratory rate might be, say, greater than 24%, greater than 24 per minute. Or his saturation might be on the lower side, say 90 to 94%. And the deadly one is the severe one. Here, the patient will be having difficulty in breathing, tachypnea. His respiratory rate will be on the very high side, more than 30. It will be very difficult for these patients to maintain saturation. Saturation might be less than 90%. Might be on X-ray. These patients might be showing typical features of an ARDS, acute respiratory distress syndrome. These patients might be presenting with sepsis or with septic shock. So in a nutshell, first, any patient comes, have a high index of suspicion. Then you classify these patients. Once you suspect that these are COVID patients, then whether it's mild, moderate, severe, or asymptomatic, because your treatment depends on the classification of the presence. You cannot treat everyone with the same brush. I mean, you cannot paint the entire COVID patients with the same brush. You ought to know what sort of treatment we will be giving, depending on the severity with which the patient presents. Now, what are the risk factors? Now, who are the patients? We need to be extra cautious. What are the risk factors? Like, suppose a 20-year-old young man with no comorbidities, he's not having any disease. He happens to be he happens to be infected with coronavirus. Then the chances are that prognosis is very good. But who are the ones that we need to be very careful, where the prognosis of COVID is not as rosy as we might think, or as some of the local quacks or some of the local politicians have made out to be. Now, the risk factors, elderly, yes, elderly parents above 60 years, anyone above 60 years, they are immunocompromised. So they have to be be extra cautious. Long-standing blood sugar, diabetes, not just corona. This diabetes is a deadly disease for any disease. Same with corona. In diabetes or in hypertension, like your immunity is compromised. Obesity is the basal metabolic index. If it is more than 30 or 35, you have to be extra cautious. And then the patient might be having a history of cardiovascular disease, cerebrovascular disease, chronic kidney disease. These CKD patients, they might be on hemodialysis. So you have to be these patients are very prone to not have this infection, but their outcome, their mobility, the mortality will be higher than the general population, than the lesser risk population, or the healthier population, than cancerous patients. They might have undergone radiotherapy, they might be on the very high dose of steroids. They are totally immunosuppressed, immunocompromised is the correct terminology which I might use. So these patients, they don't just acquire this illness, but their outcome, I mean, the mobility or the mortality is it's on the darker side. So you have to be very careful with these patients. Now, treatment. So, as I told you, you cannot paint the entire community, the entire COVID patient with the same brush. It depends on the type of patients. Like we classify the COVID patients into the mild, the moderate, and the severe patients. And the mild cases like, okay, slight fever, little bit cough, but maintaining saturation, no breathing difficulty. So home quarantine, India being an overpopulated country, initially we were very the government or some of the NGOs, they press the panic button. They used to send all the patients to the hospitals. Now, this is no more the protocol. What we do is that we advise these patients to go in for home quarantine or COVID care local center. And we symptomatically manage the patient. If the patient is having body ache, we give a painkiller. If the patient is having fever, some paracetamol or something like that. And like for high risk cases, like individuals who are exposed to COVID patients, we give a hydroxychloroquine, the dose of which is 400 mg BD on day 1 of the presentation, followed by 200 mg BD, for the next 4 days. So by and large, symptomatic patients, the outcome is fantastic. The patient recovers, but only thing is that you need to be protect the other elderly patients, those patients who are more prone to develop this disease, because you might be a healthy individual. I might be suppose healthy, or a young man of 24 years might be infected with COVID. He might be healthy. He might be having just mild fever, but he might be living in a joint family where he's having a grandmother of say 70 years with chronic with diabetes, chronic hypertension. Now he might transmit the disease to his elderly grandmother, and the prognosis is not very good in his or her grandmother or grandfather. So you have to home quarantine and symptomatic management for pain relief, for fever, for cough you have to do it. The other is the moderate cases and the severe cases. Moderate case, I told you, and severe cases, they'll be presenting with tachypnea, ARDS, sepsis and shock. Moderate cases, okay, patient might be having breathing difficulty, but saturation, okay, might be maintaining on 90-94%. Patient might be tachypneic in moderate cases, but the respiratory rate might be says around 24, hovering around 24. Now, what do we do in these patients? Now, these patients we admit in dedicated COVID healthcare center. We do the symptomatic management. Patient is having fever, treat fever. Okay, patient is having body ache, treat those symptomatic management you have to do. Now, such patients, we advise when they're awake to sleep in prone position. Okay, we know the supine position, prone position for better aeration, for better ventilation of the lungs. So we advise the patient to go in for to sleep in the prone position. The outcome we have seen, it's better. The patient saturation improves because the ventilation, the dependent areas, it helps in the aeration. The other is that we start with an anticoagulant like Lexine, low molecular anticoagulant, once a day, depending on the body weight. We start with Clexine, enoxaparin, other things. But Clexine being cheaper, we prefer in government institutions. Hydroxychloroquine, yes, as I've said earlier, 400 milligram BD on day one, then followed by 200 milligram BD for the next 4 days. Then we monitors. Monitoring is very important in such a patient. C-reactive protein, ferritin, D-dimer. Then in that case, we used to give favipiravir, but personally, the outcome has not been that good with this drug. Remdesivir, yes, provided remdesivir we give in moderate to severe cases, and those that present early. I mean, like they are able to maintain saturation. Once the patient is intubated, this remdesivir is of no use. So remdesivir, when do we give? What are the patients? Those patients who are having moderate to severe cases, those patients who presents early, those patients who maintain saturation, and those patients who are not intubated. Otherwise, it's not of much benefit. Then the plasma therapy, yes, plasma therapy, it has been started in some of the institutions. We too have started, but you have to give plasma therapy early in the course of disease, and that too in moderate and severe, not in advanced. In advanced cases, it's of no use. Mild case, we avoid giving plasma therapy. Then yes, some steroids like methylprednisolone, dexamethasone, particularly if the patient's oxygen requirement is on the higher side. Okay, now coming to the severe cases. Severe cases are those that I've mentioned earlier. Like they might, if you look at the X-ray picture, they'll be showing the typical features of ARDS. They might be severely tachypneic, respiratory rate might be above 30, might be difficult to maintain saturation. These patients might need NIV ventilation, HFNC, or they might be intubated. These patients requires to be admitted in dedicated hospitals, COVID hospitals. They're shock. These patients are on shock. They have to be hydrated properly. The vasopressors have to be started. The shocks have to be corrected, and they might require, depending on the patient's condition, non-invasive or invasive ventilation. And the prognosis in elderly patients is not that good in those patients who require invasive ventilation. Yes, non-invasive ventilation, my protocol, in our institutional protocol, we try to put, I mean, the patient preferably on HFNC, that is high flow nasal cannula. Up to we go as high as 60 liters, or NIV, and are like it's only we fail to maintain saturation. Only our last resort is that we put the patient, we intubate the patient, and we put the patient on ventilators. As far as possible, we avoid the patient putting him or her on ventilator, as it becomes very difficult for elderly patients to come out of to wean away from the ventilator. So what is ideal? There's no such thing as ideal, but what is best for the patient, it depends on the severity, on the age of presentation, and if we see if the patient is maintaining saturation, which FNC, we continue with HFNC or NIV ventilation. Intubation, yes, but it is our last resort. And then yes, of course, the other thing that we give low molecular weight heparin, because they present with typical features of DIC. These patients are not promptly treated. Then steroids, yes, like if the patient is on shock, the patient's oxygen requirement is on the higher side, we give methylprednisolone or dexamethasone depending on the body weight. We adjust the dose accordingly. Now coming to, we have seen the COVID patients. How do we diagnose it, and what are the investigations? We have seen the treatment modalities. What sort of treatment what sort of patients? No. When do we discharge? Now, what are the discharging guidelines? So again, we divide this patient into broadly into three types: the mild, the moderate, and the severe. In mild cases, do we need to do an RT-PCR? No. The answer is an emphatic no. No RT-PCR, no TrueNAT test, no rapid antigen test to be done before discharging. What we do is that 10 days after onset of symptoms and the patient is having no fever for 3 days, we discharge the patient. There is no need for doing any test. Just self-isolate for 7 days after discharge. Now coming to the mild cases, so nothing to be done. Just observe. If you're symptom free for 10 days, there's no need to go for any test, and just self isolate for some days, and then you can discharge this patient. This patient is very, very safe. The moderate cases, if the fever resolves within 3 days, and if the patient is maintaining a decent saturation, say above 95-96%, on room, that is without the help of any oxygen for the next 4 days, then we can discharge this patient 10 days after onset of symptoms. And then we advise such patient to self-isolate home for another 7 days. Okay. If fever doesn't resolve within 3 days or oxygen demand continues, after complete resolution of symptoms, we'll continue to keep this patient in COVID centers. So if the patient is symptom free, if the patient is not requiring oxygen for 10 days after, again 7 days, we'll ask for home isolation and we can discharge this patient. Again, there is no need to go in for any test before discharging such patients. Now, the third category, the severe cases, those who present with ARDS, those who present with shock, they have to be completely cured. In a nutshell, they have to maintain saturation. They must be afebrile. They must come out of shock. In short, these patients have to be totally recovered, and not just totally recovered from any sub symptoms. We undergo a test, and the polymerase chain reaction, the RT-PCR, that must be negative. Initially, we used to insist on 2 RT negative, but of course, we told with times, lots of changes have taken place. Lots of protocols, treatment protocols have undergone change. Lots of like a discharge criteria to have changed. Now, our discharge criteria, if a severe case of corona is admitted, the patient must be totally symptom free. We undergo RT-PCR only once. If it is negative, we can safely discharge these patients. Okay, prophylaxis. What need to be done to before you can get infected with these? What are the steps? So the golden rules, like as my very close friend and my colleague, my batchmate Dr. Sailesh has mentioned, like you have to maintain social distancing. You have to maintain a very good immunity and avoid mixing in crowded places as far as possible. Wear a mask when needed, avoid unnecessary travels. These things are mandatory for all the population, but for asymptomatic healthcare workers who are involved in managing suspected or confirmed cases of COVID-19, and for asymptomatic frontline workers like paramilitary, police personnel who cannot afford to leave the roads. Imagine the state of our traffic without the traffic signal police, or the Jawans, if they leave our borders, what our neighboring friendly country China will do. So they have to be stationed at their post. They are doing a noble service. So these patients, what prophylactic measures should be taken, or for that matter, household contacts of lab confirmed cases. So in these cases, what we do is that hydroxychloroquine, the drug that is the US President Mr. Donald Trump is very fond of. I mean, he literally begged to us for this hydroxychloroquine. So what we do is that we give hydroxychloroquine 400 mg twice daily on day 1, followed by 400 mg milligram weekly for 7 weeks. We can extend it for 10 weeks, depending. Different colleges have different protocol. ICMR initially said 10 weeks, but now they have come down to 7 weeks. And for household contact, we give the same dose, 400 mg BD on day 1. Then weekly, the only difference is instead of 7 weeks or 10 weeks, we give it for only 3 weeks. Now, warnings: who, before giving hydroxychloroquine, who have to be extra cautious, or hydroxychloroquine should not be given to which patients? Hydroxychloroquine is contraindicated. We don't give hydroxychloroquine. We don't give, in a nutshell, no hydroxychloroquine to be given in patients who have retinopathy, who are allergic to hydroxychloroquine or 4-aminocunolene compounds, the patient with a genetic disorder, glucose 6-phosphatase dehydrogenase deficiency, any cardiomyopathic patients, or those who have any cardiac rhythm disorders. We all know it causes widening of the QT interval. So we don't give, not avoid. The better terminology is that we don't give hydroxychloroquine. And we don't recommend hydroxychloroquine for younger people, like those who are adolescents, less than not exactly adolescents, those who are less than 15 years of age. In pregnancy, yes, we know that this is a territory drug. We should give in pregnant females, and of course during lactation. So we don't give this drug to younger patients less than 15 years, pregnant female, and we avoid giving these drugs to those mothers, breastfeeding mothers. So coming to the conclusion, stay safe. Don't be very much like afraid. Don't panic. The mortality rate is very much lower on the Indian side, particularly in a country. And before concluding, just take away the points. It's a coronavirus is the RNA virus. Okay, the virus might present with some mild with classical symptoms of fever and sore throat, or it might present with some atypical features like loss of taste sensation and all, loss of appetite. Then diagnosis, you should have a high index of clinical suspicion. Then you can go in for RT-PCR or rapid antigen test, depending on the needs. As I've discussed earlier, who needs to be undergoing RT-PCR, who needs to undergo rapid antigen test. Rapid antigen test, even if it is positive, if it is negative, and if you suspect a patient to be suffering from infected with corona, then you go to RT-PCR, which is an expensive and time-consuming test. Once you diagnose a case as a case of corona, you classify this disease as asymptomatic, mild, moderate, and severe. Mild, only symptomatic management, home care. Same with moderate. Only thing is that we had steroid, we had we had low molecular weight heparin, and depending on the year, we can give remdesivir if it is earlier in the course of disease, and in the severe form, patient who presents with shock, along with COVID symptoms, patient with classical features of ARDS, we have to do the basic management of shock and ARDS. And yes, plasma therapy, remdesivir, these are of hydroxychloroquine, vitamin C, all those things. These are of very much beneficial. And discharge criteria same, mild and moderate. You don't need to go in for a test. The patient can be kept for home isolation. If the patient is symptom free for the last 10 days, yes, we can discharge after another 7 days of isolation. For severe cases, the patient have to be totally treated, and then we have to go. Initially it was RT-PCR for 2 negative, but now we need only 1 RT-PCR negative. That's it. So in a nutshell, this is all I have to say. Thanks a lot.
Thank you so much, sir, for
Okay,
such an informative session. Well, we have few questions that will be taken up at the end of the session, because we are running short of time, sir. So we'll move forward.
Okay, thanks.
So, yeah, telerehabilitation, also known as virtual care, is the delivery of professional rehabilitation services, such as the services of a physiotherapist or physiotherapist assistant at a distance. Usually, telecommunication technology, service delivered medium. Well, Dr. Joshni Khan, ma'am, senior consultant physiotherapist and HOD, Advanced Physiotherapy and Rehabilitation Center, Patna. She is an associate professor, IIHER Patna, is here with us to take up the session. Welcome, ma'am. Joshni, ma'am.
Yes, ma'am, we can see your screen. You are on mute.
Good evening.
Good evening, ma'am.
A very good evening to all, and a warm welcome to the delegates and all the participants. So I'll be talking about telephysiotherapy in general. As Dr. Alpna ma'am has already talked about tele-rehab of the neck. So I'll be focusing my talk more on my own experiences, which I learned during this last few months. So I've tried to keep it as simple as possible so that our young professionals who are new to this field they have confidence to start it. It's not easy. It's not tough. It's very easy to do. So I'll just start. As we know that telerehabilitation means online treatment, that is treatment from a distance. So it is there in the progressive countries since 2 decades. But in our India, in our this country, we are just starting with this concept. Telemedicine, as American Telemedicine Association defines it as a remote delivery of healthcare services using telecommunication. Even WHO said that it is the need of the hour, like because it is healing at distance. So we don't need to uh, touch the patient when we are practicing this telemedicine. So this is the definition of telephysiotherapy, use of technology to provide physiotherapy services. So video conferencing provides direct contact between patients and physiotherapists. Either we can have a one-to-one session or a virtual group settings also. Now we all know progression of technology. We started with telephone, we started with pre-recorded video materials. Then we progressed to live video conferences and interactive softwares, virtual reality and virtual environments. Now we are in the phase of smartphones and smartphone applications. Now, why telephysiotherapy? Why we are discussing this? One, stay home, stay safe. That is the only way, only mantra to be safe now. But those patients who have pain and those who have difficulty to move, they need our therapy, they need our help. And forget about this pandemic time. Even we have patients who come from remote areas. So what about those patients? So for them, telephysiotherapy can be a solution. Now the question arises that why should we go for this virtual communication? Why don't we wait for this time to get over? So the question is that we aren't skipping anything. We are doing cooking, we are practicing hobbies. We have even set up work from home offices at our homes, workstations, and even kids have their online classes from home. So why should we skip good health? Now, for whom this telephysiotherapy is appropriate? Patients who are having pain, work from home, those people who are working from home, and kids who are having online classes, they are having postural problems. So for them, this telephysiotherapy is appropriate. Bad routines, we know that all the ladies, almost all the ladies are having these problems because of household chores exertion. Elderly people, they are not coming out of their houses for their walks and exercises, so they have issues related to restricted body movement. So for them, this can be a blessing. And people who are missing the regular physical therapy sessions, like you have patients of stroke, post-operative cases, fitness classes. So because of COVID scare, they are missing these therapy sessions. So for them, telephysiotherapy can be practiced. Now, benefits are again convenience and privacy. Travel time is saved at this flexible clinic hours, and most of all, we can bring experts to remote locations where patients do not have this access to good facilities, and it is cost effective also. Benefits to physiotherapists: you can work from home, you can have increased job satisfaction, you can reach your patients, you can have increased patient reach. Lots of patients are calling during lockdown, ma'am clinic kholiye please, humko aana hai, humko problem hai. So you can treat them from the distance, and you are connected to a global network and updated standards of practice because of this telephysiotherapy. Now, methods to deliver telephysiotherapy. One is video conferencing. That is the most common method what we are using nowadays. You can go for consultations, you can go for diagnostic assessments, you can deliver treatment interventions, you can demonstrate exercises, and you can have a verbal and visual interaction between the participants, between the patient as well as the physiotherapist. Now, coming to virtual environment, this is a new thing for, I don't think many of the practitioners are practicing this in India. So we can design environments which can be used in physical rehabilitation. Smartphone applications also are available, which can provide medical support. So I will be talking more on the video conferencing thing because I'm just new to this field and I've started it. So I'll be making it very simple. Now assessment, what are the assessment modalities we can do? Subjective means history taking regarding what is the problem of the patient and what is problem, what aggravates, so that what how we are taking in a face-to-face session, same in the same condition we can take it, same situation we can take it in the form of the online consultation. Objective assessments, when we come to object we may have to skip some assessments, so I will be discussing that in the detail. Now, gait assessment and re-education can be done. Assessment of fall risks, because the patient is at his home, so we can assess whether there are risks of fall that can be assessed. Functional assessment, adaptation of their of the patient in their home environments, and the ADL assessment. This can be done by tele-physiotherapy. Now, coming to treatment modalities, what all treatments we can prescribe, we can give to the patient. We can go for exercise prescription, supervised exercises via video calls, and exercise prescription you can send, you can record a video and send them, and progressions. Then home-based modalities like heat, cold applications, even portable TENS machines that can be prescribed, and then we can teach the patient how to use it. Then self-administered techniques, certain stretches, soft tissue frictions under the direction of physiotherapy. So if the patient is like he's able to understand and he's able to follow your commands properly, then you can teach them some self techniques. Again, education and reassurance of patients and caregivers. That is very important, reassurance of patients as well as caregivers, especially for patients who are going through some disability issue like stroke patients or cerebral palsy kids. So for those, it's very important. And you can teach their families how to perform stretches or home exercises. Even coming to bracing, you can teach them how to wear it, how can remove it, and you can have a brief observational assessment of whether the brace is fitting or not. Now components, what we can do and what we cannot do. I'll just skip it because I'll be just so coming to goal setting, that we all of us know that in goal setting we have to involve our patients. We have to, so together the patient and the physiotherapist should set the goals, and then we can track keep a track on the goals. This includes functional outcome measures and other measurements under the direction of physiotherapists. Functional outcome measures like you have your get up and go test and functional reach test. You have certain outcome measures. Those can be checked before and the commence or and the when we have after a few weeks or after a few days of therapy, that can be done if you want to make it more objective. Very important thing which has to be uh, in our minds is that we should use our professional judgment. That is, it is not that every person will benefit with telephysiotherapy. There may be some patients who may not, may be risky for them. So for example, if a person has some safety issues, suppose gait issues, suppose you have stroke patients or you have paralytic patients, so you have to assess the risk, whether it is safe for them, whether you need an attendant with them. That has to be assessed then only, because you are not there physically present to help them. So that has to be judged professionally. Privacy of personal health information has to be taken care of. And if there is a need for hands-on assessment and treatment, suppose there is a condition like, suppose you have frozen shoulder, which is quite stiff. So for those conditions, you know that home exercises may not help him much. So maybe you will have to go for a hands-on assessment. That for those conditions, maybe telephysiotherapy may not be that appropriate or maybe very time-taking. Now, what are the barriers? Technology failure that everybody knows. Challenges, you may have a weak internet, or some people who may not understand this tech. They are not tech savvy. So you'll have to plan and practice. You'll have to teach them, guide them how and be patient if they have questions. And medical emergencies, you have to have the address of the patient. If there is a medical issue, suppose you have to be prepared to act like maybe you'll have to call an ambulance if there is a medical emergency while you are in a session of telephysiotherapy. There is very limited research in from India regarding this role of, but whatever little bit of research has been done, results are promising. So need is that we need to have an alternative model, and which will minimize the distance and time and cost, and it will promote the quality of life from their home and community and environment. So there is a need that we should go for more trials and studies on the same issue so that we'll come to know whether it is working or not. Okay. Now, how to practice telephysiotherapy? Very briefly, so this is the guideline from American Academy of Neurology. General principles of telehealth: carefully observe, demonstrate, if possible, stay zoomed out, and have an eye contact with the person. Repeat. For certain scales, you may need an examiner present. And if the patient is uncomfortable doing some examination procedures, you may have to skip it. That is very important. Now, just briefly, I'll go this musculoskeletal assessment. I had this patient who called me during lockdown. She had some issues related with her shoulder problem. So I told her that time Zoom was not very, people were not friendly with Zoom. So I told her to just guided her through a video message and told her to just do these movements, and so that I can have a, so this is regarding, so she's showing the location of the pain and different movements. She's so flexion through elevation through flexion she is doing, and she was pointing out where usually she has pain. Then yeah, this was the issue with her when she used to get the pain, the shoulder. So the location of pain the patient can show. And then she's having problem with the elevation activities. Then this abduction through elevation through abduction. And then this functional assessment of the rotation, the range of motion of the shoulder. Yeah, external rotation. So this was a brief preliminary assessment. Then I sent her a video of the exercises, what she needs to do. Then this was a patient who had a problem with the wrist. So preliminary this thing subject on history taking, I could understand that maybe she has this decutinosinovitis. So I sent her a video to yeah, just I've cropped the video so that it is short. Yeah, wrist movements. Yeah, and in this activity she was having pain. Yeah, one more patient I had of a total knee replacement, who had to skip his physiotherapy sessions because he was not ready to allow any physiotherapist for to his home. So he developed some complications. So for him, we had a session. So this is observation. You can just see, you can observe from a distance that site of the pain. So the patient is indicating, he's showing the site of pain where he's having pain. He developed some complications regarding range and pain. This was, he had developed swelling of the feet also, lower limb, the operated lower limb. Yeah, this is the site of pain he was showing. And then the soft tissue palpation. Yeah, this I had to guide his son how to do it. So I had sent him a video on how to do it so that we could see that whether the scar is adherent or where he is having pain. So he was, yeah, he was having pain when he was bending his knee, and he was showing me the location of pain where he was having. His range of motion on the first session was 30 degrees. Now he's reached to around 50 degrees of range of motion, observational only, because I don't have a goniometer to measure from. So this is movement examination briefly. Straight leg raise test, which he was not able to do on the first session, but after 15 days of therapy, self-therapy, he is able to do this movement exam. He is able to do this SLR independently now. Now this is the range of motion test for his knee joint range of motion test. And in the sitting, whether he is able to bend his knee or not. This is the gait assessment. That is how we can do it from the back. Yeah. And now, so this was just a brief outline of how we can do. We can just modify our assessment for different conditions. Now, neurological assessment, we have a brief guidelines from American Academy of Neurology. Like first, practice with a colleague or family member. That is generally for everything, every condition. Practice with a colleague or family member, and practice with the software. When you are confident enough, then you can start. Much of the neurological examination can be assessed. What cannot be assessed is ophthalmological assessment, vestibular examination, and if you have very mild weaknesses and sensory deficits, that cannot be checked via telemedicine. Mental status examination can be through observation and basic questions we can ask him, can have a mental status examination. Motor examination, tremors can be visualized, may need some modifications. Then motor examination, we can do arm strength assessment via a pronator drift, via forearm rolling test, slowed finger taps, and decreased arm swing while walking. Get observation of gait, he may have a decreased arm swing. Bradykinesia can be checked via finger taps. Then opening and closing of hands, pronating, supinating hands. This way, we can ask the patient to do. And for complex evaluation, we may need an assistant for neurological conditions. Again, I'm repeating that we have to be very careful that whether the patient is secure, the patient should be secure when we are going for an examination. This, especially for these techniques, like whether the patient is able to pull himself up in standing, stand up with arms crossed from sitting or squatting, heel and toe walking if he's able. So we can have a quick examination of heel and toe walking. So that will tell us about the power of plantar flexors, dorsiflexors. If he's able to stand on one leg, means he's having his anti-gravity muscles at least grade 3. And then we can see in one leg standing, we can check for the Trendelenburg sign and all, and assessing lower extremity drift. So we can have a brief, we can have a broad outline of where he may be having his problem, where maybe he may be having his weakness or any other issue. For sensory examination, this is very tricky. We can we may require the help of someone who is there with the patient. You can ask them to check the differences between left and right, proximal versus distal. That needs some training, or that we need to repeat it and teach them how to do it. And different dermatomes, that is with a skilled examiner only, but for attendants, just they can draw a line around the numbness, that is general distribution, and then we can have an idea regarding, suppose you have a patient of carpal tunnel syndrome, you can go for a Fallon test, and they can show on the hand where is the area of numbness they are having. So that ways you can have a brief sensory examination. Cerebellar examination, again, finger to nose, you can just ask them to keep their finger, they can just touch their nose and the contralateral finger with their own nose, own finger. And reflexes cannot be tested, we have to have a skilled examiner. Now exercise demonstration, just a brief. So this was the self mobilization with the other limb, contralateral limb, just pushing the operated knee towards flexion. Then this, they did not have anything like a weight cuff also. I had to demonstrate with the help of a towel and taught them how to make a weight cuff at home, and then do an SLR with the help of a weight cuff. TheraBand exercises are very easy to perform. They can be taught to the patients. Neck exercises, neck stretches, this mulligans, snags and nags can be taught. So during this tele-physiotherapy sessions, this is physiotherapist guiding national rugby player Jay Jelani over video conferencing software. So he's teaching him stretches, and so the conclusion is that during this pandemic time, it is okay that we will have to go for tele. But otherwise also, when we have when we have patients, those who are living in far off places, so for them we can practice this. So this pandemic has taught us how to deal with patients who are staying away from our clinics, who are not, or who are unable to come to our clinics. Thank you.
Thank you so much, ma'am. It was very informative and useful too. So we have already seen healthcare as being very protective and innovative in approaches. So, for example, one of the key things we want to do is make sure that we identify and isolate patients very early. Well, three people can get same cancer, and one will have a very dismal outcome, and one will have a great outcome, and one will have a moderate outcome. And I think we are seeing the exact same thing with the coronavirus and the COVID-19 pandemic. Today we have with us Beauty with Brain, uh, Dr. Jaspreet Kaur ma'am. So she is the principal at Mahatma Gandhi Physiotherapy College, Ahmedabad. She is my teacher as well and an excellent guide. Welcome, ma'am.
Good evening, Smita.
Good evening, ma'am.
It's a pleasure and honor to be a part of this. Well, thank you so much to IAP and especially Smita for inviting me for this. Today, my topic is the vital role of physiotherapy in COVID-19 post-viral fatigue syndrome. Now, we all know COVID has affected our lives very badly. Nobody has been able to estimate what will be the effects when it started. When COVID started, there were a lot of symptoms which we never knew. But do you know that does COVID stops even after you have overcome the infection? I don't think so. Still, people are facing lot of symptoms, lot of problems which are continuous after the COVID also. For example, one of them is very common is prolonged fatigue. Basically, the post-viral fatigue is when you have an extended period of feeling of unwell. This post-viral fatigue is usually seen with so many of people. Usually the viral infections which we see, mostly this condition occurs. And now, even with COVID-19, the symptoms have been reported. I'm sorry, there's a error. So what is happening? This COVID has led to drain of energy. It's not only the energy which has been drained, the person feels that even after a lot of rest, he's still not able to do anything. He feels very lethargic. He doesn't feel like doing anything. He feels even he has slept the whole night. In the morning, he feels he's not slept. And there's a lot of sleep disturbances in the night also. They don't have a cause. So they don't know why it is happening. And if the patient is suddenly getting out of the bed, he may have lightheadedness along with it. Or he may feel that the heartbeat has increased. There's a rise in heartbeat. Or even if he takes few steps, he feels that there's shortness of breath. And lots of such symptoms are coming after the infection has healed, after the patient has been tested negative of COVID-19. No, this prediction has led to number of complications with the people. Now, basically,
Excuse me, ma'am. Dr. Jasprit, sorry to interrupt you. You are on mute. Can you please unmute?
I'm sorry, there was a technical issue with this. Now we were talking about the symptoms of post-viral fatigue. We'll see that patient have various symptoms and they vary from patient to patient. Very commonly, the most commonest one is significant lack of energy. Even the patient after sleeping the whole night or taking the rest whole day, still he feels that he is not active. He cannot perform his activities. He's not able to do, he doesn't feels like doing anything. Then he may all complain of muscle or joint pain, which is unexplained. He may not have done any work, no activity, but still he complains that he has muscle pain or joint pain. Then very commonly there are sleep disturbances. He may have a disturbed sleep throughout the night. It may be like he may get up a number of times and the reasons may be unknown. He feels restless throughout the night, even without any activity. And very commonly, when the patient gets up out of the bed and he wants to stand, he may feel dizzy. There may be dizziness, lightheadedness to the patient, or sometimes he feels that his heartbeat has increased. He feels there's a shortness of breath if he takes 2 or 3 steps. Just simple steps. If he wants to use the washroom and he goes from the bed to the washroom, and in that case only he starts feeling there's a shortness of breath. More of there's mental fogging. He's not able to understand. He doesn't knows it's not that he is intentionally doing it. The cognitive impairment there have been researches which has proven that they are not able to do multitasking. It becomes difficult for them to do multitasking. And other symptoms like sore throat, and they may carry even after the patient has been tested negative for COVID-19. These symptoms may persist for a post-viral fatigue syndrome. Now, I just discussed that what as a physiotherapist we do, we say, let's do some activity. What others will say, no, we should do some activity. Let the patient attempt, aap chalo, aap ye kaam karo. But sometimes just a simple daily activity of going up to the kitchen or working a little day-to-day task or a small exercise, a very simple exercise can worsen the symptoms. Sometimes those gentle activities also can help, are not helping. They are moving the patient back into that vicious loop, which is caused because of this illness and disability. So we need to understand the basic problem that the patient himself wants to move ahead, but still cannot. So why this is happening to it? Now we can see, I have a research, we saw this, and it said that this type of post-viral is not new. If we all know, after COVID-19, we have been very much discussing about the Spanish flu, which occurred in 1980. And researchers show that physical exertion was also cited a factor deteriorating the recovery or even leading to death. And fatigue was one of the most common term consequences of Spanish flu. So they said that half of their sample, the study which was conducted, they said half of their samples throughout their recovery reported 64% of patients reported fatigue even after 3 months, and 54% reported after 6 months. And this thing lingered for few patients, like 60%, it lingered for 12 months. So it's just, we can understand that this condition is just not a simple one. Sometimes we may think that the person is just making excuses. It's not like this. He or she is not making excuses. It's happening to them. Now, what is this? So looking into the literature, I found out that chronic fatigue syndrome, or what is myalgia and encephalomyelitis, and COVID-19 are basically related. Now, what the researchers showed in the present article, which was published in 2020 August, they said that because of this COVID-19, this chronic fatigue syndrome is spiking in the world. Number of patients are coming, they are seeing number of patients which are experiencing and which are deliberately, they are showing these symptoms. Now, what is CFS basically is, or the chronic fatigue syndrome? It's basically profound fatigue, means it's a unlimited, means it's a full patient cannot even define what fatigue is basically for him. He has sleep abnormalities and there are, unusual pains for the patients. And the very important diagnosis for CFS is the symptoms are worsened by exertion. A little exertion can worsen the symptoms for the patient. So patients, they have overwhelming fatigue, which is not at all improved by rest. And similar symptoms, the studies shows that such similar symptoms are now being seen post-COVID. So COVID patients, after recovering from the infection or after being discharged from the hospital, or previously as sir said that there are 3 moderate mild cases, whatever, after or home treated patients, most of them now are facing this fatigue syndrome. Now why it happens? The question is why? What is the reason it is happening? See, because COVID-19 is something which is not known in previous literatures. The scientists has been making studies presently and intensive investigations are going on. Still, they say the causes are uncertain. But the other reasons which have been unfolding is, one of the very much reason is the release of a chemical called cytokines. Now this leads to a cytokine surge or a cytokine storm. Now what do you understand by a storm or a surge? See, we have an immune system in our body. So that immune system controls whenever infection occurs in our body, we have antibodies released to control, and this activates our immune system and it generates those antibodies, and we have a reaction that it fights against that infection. But what happens in this is that the immune system goes bizarre, it goes absurd, the signals are going on, but the immune system is not able to respond. And there are lots of, it's not just one thing which is happening, there are lots of, the metabolic system is also in a absurd manner, the other genetic factors are occurring. So there are a lot of changes at the humoral and the cellular level which causes this. So because of this, there's a superimposition basically. So because there is a bizarre method, or you can say a overactive response of the immune system, plus there's a low grade inflammation. Now these both combine, and other genetic differences or few environmental effects, they combine and they superimpose to lead to this infection. So what happens? It is happening, it again turns a vicious cycle for the patient. So he is not, the role of immune system, what is happening when there is a pro-inflammatory mode is going on, it will affect the muscles, which in turn is going to affect your cognitive factors. Again, this will affect you into lethargy, and the signals are not correctly going, and there's a depletion of the energy and you feel exhausted because of it. Now we see, they say in this study which was published in June 2020, they said, as happened after the SARS outbreak, a proportion of COVID-19 affected patients may go on to develop a severe post-viral syndrome we term as the post-COVID-19 syndrome. So basically what happens, even a simple exercise can lead to post-exertional malaise in the patient. So it is a relatively high level of fatigue or exertion which the patient sees. So the article published here also tells us the patient, the author himself saw a person who was 42 years old male who shows the symptoms of COVID from 3rd to 15th April 2020, during which time he was virtually bed bound for about 2 weeks. And at the end of April, he had contacted some osteopathic clinic, and they had calculated his fatigue related scale, and they found the score of 164. But on 5th May, later on, when the patient started complaining of severe physical fatigue, insomnia, difficulty reading with the brain, fog, general malaise, dry skin, and increased anxiety. Also, other symptoms of tenderness, lymph nodes, enlargements on lymph node affections were also seen. So, this can say that definitely researchers are leading us to a conclusion that post-COVID syndrome or the fatigue syndrome is very much now coming up with the patients of COVID-19. Now, what as a physiotherapist we can do? What is the role of a physiotherapist into this? It is a thumb rule. Best approaches is rest, nutrition, sleep, and physical activity. Now, how we need to proceed? I said rest. Now, and before I just termed that even after rest, the patient is not able to get into back. He's not able to feel good. Even rest deteriorates. So how are we going to proceed into this? Now, we have the 3 principles. Basically, fatigue management, if we have learned in physiotherapy, we go for the energy conservation techniques. And same pattern we will be following for this post-COVID also. So what it is says, we need to have the 3 principles: pace, plan, and prioritize. Pace. There has to be pacing strategies. For example, for pacing, what do I mean by pacing? Now, pacing is, example, somebody wants to climb the stairs. So what is happening if there are 10 steps? What you have to advise and how you have to tell him that if you climb 2 or 3 steps and you're feeling exhausted, please take a rest of 35 or 40 seconds and then climb another 2 steps. Again, take a rest and then another 3 steps. So this is basically the pacing strategies. You don't have to push. You don't have to, no, go ahead, you can do it. So this you can do it can have an adverse effect. So here, after this, it is needed for that a slow, steady thing has to be proceeded ahead for this, in this manner. And it's like, even if we see the researchers, previously what was done was graded exercise therapy was advised for the post-fatigue syndrome, because this post-fatigue syndrome is not only with COVID, it have been seen with many other viral infections previously also. As I just discussed, as we saw in Spanish flu or other viral diseases which occurs, many of the patients see this. But the recent guidelines of NICE, they say that these graded ones should not be used basically for the COVID-19 patients or the patients which are recovering from COVID-19 fatigue, basically. They are not, according to them, it is not effective in every patient. Rather than giving them an effect, they are deteriorating the patient recovery. So the standard principle is principle of progression. And so they have, I just spoke, they have removed the graded exercises from this thing. Now what we have to do? See, I will be just repeating those things because it is the only, see, it's only the patient and the therapist who can jointly work. It is not just the therapist has to decide a therapy and he has to dictate. Very well, just ma'am told us about tele-rehab. So this can be also added into tele-rehab. You have to have meetings with your patient. You have to look into his needs. And then, as previously it was conveyed, we need to have a patient accordingly plan. It should be a personal plan for the patient according to his needs. So we need to understand first. First is finding the right balance on the individual basis of his activity and rest. How we are going to find the balance? It's not me who has to decide the balance for the patient. It is the patient who has to guide me first ki what are his levels, how much he is able to perform, how early he feels this he has fatigue or he feels that he cannot do the activity. So we need to work on a chart for him. So what it happens into this, basically what we do, we tell the patient to maintain a diary for himself. He has to see in a day, total day. I know the diary maintaining, because we just spoke that cognitive, there is cognitive impairment and there is difficulty. So we have to use as easier methods we can do for the patient, right? So we just need to tell him, he has to put it in a paper or something, which activities he performed throughout the day, which caused him more exertion, which led to extra drain of the energy, which made him feel better. And then accordingly with the patient, we can chalk out a plan for him. If the patient says that he did a standing activity for 15 minutes and he was totally drained of this, so we need to tell him that previously you may be able to do it for an hour, but right now it's okay, it's normal. So you need to understand your physical body levels and you need to stop, you need to decrease that time. If you were standing for 15 and you, so start with the 5 minutes, stand for 5 minutes, or let's change the pattern of work. So we need to have small flexible amount of physical and mental activities. That we need to add rest periods, we need to add relaxation periods for them. When coming to mental activities, we can advise the patient some relaxation techniques we have in our physiotherapy. We need to ask him his entertainment. Maybe he likes listening to music, some TV, but straining himself with those computer screens, those gadgets can always harm the patient. So we need to tell them they have to plan and prioritize. So first, which the three principles which we took was the pacing. So we need to tell the patient you have to rest and relax. Don't do the continuous activity. Don't stretch yourself. Go back to work when you really feel that you can. Please do not overexert yourself. Do not rush back to things, because this can increase the problem rather than decreasing the problem. We need to ask him to avoid stress, have a good diet, healthy, this. And important is basically the mental support, your assurance. You need to tell the family members to be very, very kind and gentle with them. It's a tendency. We feel infection to heal हो गया, तो अभी ये नाटक कर रहा होगा, इसको नहीं पता है. It's not happening like that. In real terms, he is definitely having a problem. And as a family, as a friend, as a therapist, it's our duty to support the patient. So we need to tell him, definitely you will gradually, it will not happen in a day. Rome was not built in one day. So things will happen. With time, gradually you will feel better. And you have to tell him, it's not happening in weeks. Sometimes it may take months for you to overcome this thing. So for this, you need to look at a proper balance of your routine. You don't need to stress yourself. So what you can do, what you can advise him, how you can make him. If he needs to do some tasks, you can ask him. Asking for help is very important. If he's not able at this moment, they should seek help. You should support them. You should tell them, if you're not right now, if you're not able to do a task, please ask. Even the patient may get tired combing their hairs, just simple grooming day-to-day tasks, they may feel tired. So they can ask their family members to groom them, to help them. That is gonna increase and boost their levels, and this is definitely gonna help them. So we need to ask them to organize, means plan. But the second principle of planning. So they should know in advance. For organization and planning, I just want to say, supposingly they need to cook something or they have to do some work in the kitchen. So it can be divided in time. एक ही झटके में सब कुछ नहीं करना है. It's like if they need to cook, they can do for first 10 minutes, they can just do the washing and sit back and rest. Then they can go back and they can sit on a table and cut the vegetables or something. Then they can take again rest and then they can cook. So we need to tell them that it is okay for you to take rest. You are not right now the same similar person. It is okay. You will get back to it, but it will definitely take time for you. You have to tell them to simplify their tasks. You please, the similar way I told. You don't need to do it, everything in one go. You need, if you are cooking, bathing, dressing, ironing, why don't you, every time we used to do tasks standing. We do tasks in kitchen standing, we groom ourselves while standing, but no worries, we can sit down, taking a seat because standing utilizes more energy. It drains more energy. So we can take a seat, we can sit down for this. This is some types that how you can do. You tying the laces, simple laces. It's if person stands and do that, he may feel that it's taken up, it has drained him. So sitting and doing, removing his shoes while he's sitting. This can be simple tasks, just simple examples to understand. Now, climate also affects the patient. So they have to understand excess of heat or excess of cold can definitely make them, it will not be easy for them to work into that manner. That energy, those levels will not come up. And we definitely, as a physiotherapist, it is our duty to emphasize them for the correct body mechanics while they're working. Because if we are guiding them for the correct body mechanics, it will consume less energy. Wrong mechanics will definitely, how to lift things, how to work on a computer, how to sit on a table. So these small things, lifting something from the floor, these small brooming at the home, during these things, and it will help them not only in the COVID-19, but that will be becoming a habit, and it can be taking for a long thing, and this will help with good postures in the later years of the life. So when I was talking about this, we can see that there are elderly people also who mostly, any elderlies have been also affected because of this COVID-19. And so there, if they're not able to walk independently, you can add on some canes, you can give them, you can use wheelchairs if they need to. And see, the patient cannot sit every time at home. We need to take them out, we need to change the environment so that the mental relaxation also occurs. They need the change, always helps them. So what we can do is, you can use a wheelchair to take the person outside, and this will decrease the energy conservation, and also helps to elevate the mood of the patient. And definitely mood elevations are somewhere affected, they do affect the patient's illness, and they increase, help the happy going person, they definitely improve more better than this. Supposingly after COVID, you're feeling very fatigued, you're not having very severe symptoms, but still you have mild symptoms, and still you can go out, but you still feel, just walking a little, you are feeling lethargic. So when you're going out, you should make the community assess quite more accessible things. So park, what we usually tell everybody is that we need more physical activity. So always park away so that you can walk. So don't use the lift and you climb the stairs. But in these cases, it will be the reverse. So what we'll tell the patient, please park near, or please do not take the stairs. We know it is a healthier version, but still your body is not into that condition that it takes that much of exertion. So use a trolley to get back to your things. So such little examples, little things can help you to help us to make those post-COVID symptoms quite, those patients in a helpful manner.
Sorry, ma'am. Sorry to interrupt.
Yes.
We are running short of time.
I'm just moving. Fine.
Yeah. Thank you, ma'am.
So it's just start by doing what is necessary, then do what is possible, and suddenly you're doing the impossible. So it's just a little push. It's a little push you have to give the patient, and that push is just not every time, not the physical push. As a physiotherapist, you're not always pushing the patient physically. You are also supporting the patient mentally and helping them, guiding them through this phase which all of the whole world is suffering from. Thank you so much.
Thank you so much, ma'am, for explaining and making us understand so well. Well, we are running short of time, so we'll quickly switch over to Dr. Rajiv Prasad, sir. He'll be simply giving an overlook on optometric point of view. And then we'll move on to Dr. Manish, sir. Rajiv, sir, are you there? Well,
hello, Smita.
Yes, sir.
Am I audible?
Yes, sir.
Wonderful. So, I'll just share my screen. So, hi, good evening, everyone. Thank you so much for giving me this opportunity to be here. Thank you so much, Dr. Smita, for organizing this COVICON. So, I'll just quickly go through the session. Now, can you all see my screen? So, I'm Dr. Rajiv. I practice in Patna and Jamshedpur, and primarily I'm into neurovision therapy. So, coming to vision, we all need to really understand what is vision, and there's a model of vision which talks about.
Excuse me, sir.
Sorry
yeah. to interrupt you. Can you please put your slide on the slide share mode so that it will be visible on the screen, entire screen?
Okay.
Thank you, sir.
Is it okay?
Yes.
Perfect. So the model of vision, which talks about where is it, what we really know about it. So it's all revolves about around anti-gravity, centering, identification, vision, and speech auditory. So what is anti-gravity? Skifting described his anti-gravity circle as a set of sub-process concerned with balance and posture, where you all come in picture. So it is a vestibular anti-gravity system that describes the process and neuromotor maturation as an individual integrates primitive reflexes and gain postural control. So I'll skip a bit, and now dynamic theory of vision, which talks about effective bilateral dynamics and body alignment. Good posture is learned. Without it, really understand what is visual space. Now coming to the other part, the organization of it is really important when we talk about muscles. It's really important that we talk about vestibular ocular reflexes and spinal reflexes, and how your muscles control your body. So directly or indirectly, it influences everything what we do. It is all the brain, the eye, which has to be really connected with the brain. If brain doesn't support it, eye is not going to work, right? So it's function like a traffic cop telling which sensation, where, and when it is to go. So functional vision, which affects associated with vestibular problem, that's instruction nystagmus. I mean, nystagmus is a jerky movement. So it talks to versions where the eye is moving actually, sluggish accommodative facility, how we are seeing, if the child has to see blackboard. So it has to be eye focusing ability, which has to be, very clearly done. Fatigue, and there are various other, visual agnosia and all. So coming to concussion clinical trajectories, it always involve, ocular, vestibular, cognitive, post-traumatic, cervical, and anxiety. I mean, you all work on all these areas, and I think the previous speaker spoke about probably ophthalmological examination. So, I mean, there is where our picture, we come in. So most of the time when we talk about headaches and all, headaches like 71%, it is, at times it is get misdiagnosed, saying that, the person has probably a migraine or something. As a matter of fact, it is more about vestibular system which is getting affected. So the common ocular motor dysfunction following TBI is like convergence insufficiency, saccadic, persuadic, ocular misalignment, accommodative dysfunction. So it's the brain who's asking for, really give an attention how the things is moving. So 70% of our brain is dedicated to vision in some or the other fashion. 80% of all sensory function goes through the eye. 90% of individual that has a concussion will demonstrate one or the more ocular difficulties. And if not addressed, yes, that leads to some other problem. So there are three pathways usually in eye care where we talk about, that is parvocellular, magnocellular, and coniocellular. So occipital lobe, it is really involved midbrain, and that actually leads, whatever we do. The common problem which happens with most of these patients, it's like double vision, blurry vision, they have light sensitivity, concentration, reading problem, a poor judgment of depth, and so on. I mean, at times when you see these kind of, you go to such places, it's really, the midbrain which gets really affected. So abnormal visual processing affects postural tone, as you can see in the picture. Now, diagnosis, what do I look for? And we really have to work in a very, aggressive manner. So cognitive issues, the linear and showing up, the visual vestibular system is really getting involved. Anxiety trajectory is showing a consequence, an unresolved vision problem. What are the common vision problem which usually we take care in our neurovision therapy center? That's blurring or fluctuating vision, eye tracking deficits, double vision, which most of the patient has after TBI or something like, and then light sensitivity. So all these things can be resolved in really, in vision therapy clinic. So non-visual symptoms, reduced cognitive abilities, balance difficulties, headaches and all. So what came first and where should we start? So we have to devote really attention to posture. We cannot attend things. Posture should be part of organization set that does not require, real attention.
Hello, sir.
Yeah.
So your screen is not visible.
Oh. Just a second. I'm not sure. Is it now?
So could you share it again?
I think just a second. Is it okay now?
Yes, sir. So now you can put it on the screen slide share mode.
Sure. Is there a place where I left?
Yes, sir.
Perfect. Thank you. So these are the common symptoms which really affects most of the time. It's blurred vision, eye tracking deficits, double vision, and light sensitivity. There are other symptoms which can be probably very well addressed by physiotherapists. So what comes first is about the postural should be the part of our national setup that does not require any regular attention, and there is a mismatch between the balance and the vision. So the priorities, what we in eye clinic, what we take care is visual issues which is getting affected, as I said, double vision, sensitivity, vestibular issues and all. And there are certain tools which we always use, and there are powers and prisms we work on to make sure that things are aligned. Vision vestibular rehab strategies, that's not started in India as such much. Currently, we are just 3 to 4 people who's actually working on that. And logical order of, treatment fixation, pursuit, saccades, versions, cognitive load, vestibular integration, and so on. So, I mean, like situations like these where, you have optical illusions are there are chances that patient may have hidden refractive errors. So behavioral characteristics of individual with vestibular problem, it's very much clear with the pictures here. Postures, yes, we work in a lot of prisms which improves their body balance, hips and all. Different kind of prisms we use in our regular practice. And these prisms really impact, because if I say an example, if a person has to play cricket, they really don't necessarily have to see the bat, they have to see the ball, and it is the eye hand coordination which is actually working. So similarly, in such a situation, these prisms and all, which really helps in making sure that things are in place, and their muscles and eye and brain is really coordinating with each other system. So vestibular ocular reflectors and gaze stabilizations, Marston ball, I mean, these are some stuff what we use in our day-to-day practice. Treatment modalities while you're tilting their head with different postures. McDonald card, Laura's card, what we use in our practice. Central vision which gets affected. And there are patching, binasal patching. There are certain other ways which we use. I mean, since we are lacking of time, probably we can some other day probably we can discuss this in detail. Sports really get affected. If you really want to get into good sports, that visual ability has to be assessed properly. Light sensitivity, the common symptoms are eye strain, visual fatigue, squinting, headache, eye pain, intolerance of light, and all of these things can be really recovered in neurovision therapy, and which causes to dry eye, blink rate. So optometric, I mean, as I said, binasal occlusion, that there are certain kind of prisms which really works. I'll just go over a little faster. Motor sensitivity, motor activity, that causes stroke, brain concussion and on. So symptoms, common dizziness, headaches, and all these things, a lot of things, these can be, covered in neurovision therapy. And that's the reason, when Smita spoke to me about to, give a deliver a talk, and I thought it is multidisciplinary approach, in where physiotherapy and vision therapists can work together. So there are certain treatment plans, and these are the common symptoms you must have seen in most of the patients who are working in, this area. So the eye tracking, an excellent, screening tool that really helps to improve the current system, which is actually happening. And, really this can be identify a potential problem. Then, Nusuko things can be really used. Vision is learned, vision is bimodal, and ambient visual system disconnects. So always start with peripheral vision exercises, what we use in our practice first, so not to go behind with further lookup and visual system. So once things improve, it is always good. And in most of the developed countries, concussion management requires a team effort, which we always say that, together everyone achieves more. And you do not have to offer therapy to be a great source of recovery team. It's always the rehab team, which is with optometry, occupational therapists, physiotherapists, audit therapists, and so on. So thank you so much for the patience listening. I know we were running short of time and we had to go a little faster.
Thank you so much, sir. I'm so sorry we had to make this cut short. Well, we know very well that visual vestibular dysfunction requires a coordinated effort between a team of medical specialists, including neurology and physical therapy. I'm so sorry. We'll have you once again, sir. So thanks a lot.
Thank you so much, Mita. It was wonderful being here. Thank you so much.
Thank you, sir.
For this opportunity. Yeah.
So now we must never forget that the highest appreciation is not to utter words, but to live by them. Exemplarily, leaders search for opportunities by seizing the initiative ways to improve and take risks.
Sorry, ma'am, to interrupt. Rajiv, sir, you can stop sharing your screen.
Yeah. Today we have again my Guruji, Dr. Manish Arora sir with us He is Dean SBS PGI Dehradun. Sir will be taking up the session by explaining role of exercise in immunity. Welcome, sir. Sir.
Yeah, ma'am. I don't see Manish sir in the list.
Well, we'll continue. Sir will be joining us after half an hour. So, because he had one more webinar to go on, so he'll be joining us at somewhere around 7:45. So we'll continue. So now we have Dr. Sunanda Sampath here. She is a founder of Growing India. This is an organization which is working for geriatric patients. Hello, Sunanda. How are
Hi,
you?
Smita. I'm good. How are you?
Very fine. So shall we start now?
Yeah, sure.
Sorry, we are running short of time.
Yeah, I will try to make it as quick as possible. Thank you for giving me this opportunity. And this before I start, I would just say a thanks to Vijay Balaji, who was also supposed to be with me for the presentation. But due to some personal reasons, she's not with me today. We'll quickly start to the presentation now. Okay. So physical activity in seniors during the pandemic. So now we are in a state where two pandemics are meeting each other, right? So the world is experiencing a completely extraordinary life altering challenge. And many countries are now forced into the social distancing and stay at home policies, which has made our life completely change. So it is very hard to predict when this pandemic is going to end, and even so, even more harder to predict what are the outcomes because of this pandemic. Like the previous speakers has already told us, it's very difficult to understand right now what is the impact on the lifestyle diseases. But we could definitely hypothesize that this health crisis will impact and accelerate the problems is what is expected in now. So while of a different nature, okay, there was another pandemic sometime in 2012, which was named as the physical inactivity. So many organizations are fighting here and making their own efforts to increase the physical activity and but unfortunately at the current status, the expected rate, there was a global goal that was set to reduce the physical inactivity by 10% in 2025. However, the current scenario, it shows that we will not be able to reach the set goal. Okay, now here is the graph. Here is a chart which says about the leading causes of death, the most 19 leading factors, of which if you see, the physical inactivity comes at fourth, just next to high blood pressure, tobacco use, and high blood glucose. So which means it's a very, very important and critical in our lives today. Without physical inactivity, it is going to cause a lot of problems. So the fourth leading cause of death worldwide is nothing but physical inactivity. So every step counts. Now, if you see, about 5.5% of the deaths across the world is due to physical inactivity. So every step that you count can reduce the heart disease by 6%, reduce diabetes by 7%, reduce the incidence of colon cancer by 10%, and reduce breast cancer by 10%. So this is what is anticipated. And it was also found by Lee and his colleagues that about 5.3 to 5.7 million deaths globally from non-communicable diseases could have been theoretically prevented only if these people had actually been physically active. So this map shows the global inactivity. It's a growing pandemic, as we all see. And here India stays with 34% of our adults are inactive. This is a huge, significant number. And we, in fact, definitely have to emphasize and try to change this, to a this dark orange into a normal white. So we physiotherapists have to work towards it. Physical inactivity is a very important risk factor for non-communicable diseases, according to the United Nations. Now, what is the problem here? Here, I'm going to focus more on the geriatric persons. So that is why I have this graph here. So this is by the Singapore Center for Aging Better. So if you see by the age of 60 to 64, almost 70% decide not to move. Okay, and when they reach about 65 to 74, about another 80% decide not to move. And when they're 75 years old, very sadly, by 90% decide not to move. So this intention, this attitude towards movement is the biggest problem that we are facing today. It's a very sad trend, and this has given rise to many non-communicable diseases. Okay, now here we have the guidelines for the seniors specifically. The first and foremost is 7 to 8 hours of sleep. Second, minimize the sedentary behavior, that is regularly interrupt sitting. That is, it is expected every 30 minutes, seniors are expected to get up and have a 3 minutes of some quick movement or a quick stretch, right? And the last and foremost, the physical activity recommendation says 150 minutes per week of aerobic moderate physical activity, or 75 minutes of vigorous physical activity. And there is more emphasis on strength training as well as balance training. So if these are the recommended guidelines by the WHO, so we are supposed to reach, achieve this kind of a guideline, and this is our target. So now the stage is set. So we are going into the next slide. So what is the pandemic actually happened, made the physical pattern into? Has it worsened? Yes, definitely. So here is a report by Fitbit. Okay, this is sometime in the month of March. So if you see, India is still around only -6% when the pandemic was not so so very big in India at that time. Whereas if you see in the United States, there was a -12% decrease. Europe had the maximum decline in the number of step count. So about -34% was the decrease in the step count. That was according to the Fitbit, which is our wearable device, tracking device. So now this is the latest by Google. This is the community mobility reports by Google. So this is India's data. If you see the movement as far as for retail and recreation is concerned, there is a reduction about -61%. And for the pharmacy and supermarket, -28, parks, -59. So totally, if you see overall, there is most of it is completely negative. So the movement happening is only in the residents, right? So the rest of the movement has completely come down. So this is what the COVID pandemic has made our physical activity. It is more and more declined us. So this escalation of coronavirus, over 1 billion of people are now faced with restrictions, varying degrees of confinement. And now with the absence of SARS, vaccine, it has become mandatory to follow this stay home and stay safe policy, right? And now what is happening when both the pandemics meet? So now we already have a pandemic since 2012, and there is another pandemic right now in 2019, the COVID pandemic. And what is more added, the government policies of stay home and stay safe, right? So now there are 3 ways I'm going to talk about more on physical activity. So what can moderate physical activity do to us during the pandemic? So there are basically mainly 4 different ways in which moderate physical activity can help us. First is it enhances the immune system. Second, it improves the chronic conditions. Third, it is a great stress management tool. And it has an impact on COVID if one is affected. Okay, so we all know these are major problems that we are facing today because of the pandemic. Now, first, let's talk about the impact of physical activity on the immune system. The first and foremost change is hemodynamic change. So what happens when we exercise? When we exercise, we automatically have a gush of blood flowing. There is a vasodilatation, and this vasodilatation is going to mobilize the leukocytes. Secondly, if you take the sympathetic system, it is going to get activated and it will release catecholamines. Now, there is also going to be an activation of hypothalamic pituitary adrenal glands axis, which results in a release of glucocorticoids. So all these 3 reasons, that is the hemodynamic change, the sympathetic change, and hypothalamic pituitary adrenal axis change, will all increase the leukocyte production and mobilization by up to 2 to 4 fold. So which acts as a primary immune protector. Apart from that, there are other ways as well. The fourth way is the mucosal lactoferrin. So this is nothing but a small enzyme that is being released in the mucosal cavity, and it is seen to increase for at least 2 hours after physical activity. This acts like a first-hand barrier, first-hand barrier for the RNA infections. And next is the lymphatic system. So if you look into the lymphatic system, normally they have an auto-regulated system which actually pumps the lymph. But however, when there is a skeletal muscle action happening, the contraction of the skeletal muscles will definitely help in mobilizing the lymphatic tissue, which again helps in the immunity. So apart from that, we also have, when we exercise, our central adipose tissue getting better, the fat mobilization happening, reduction of fat accumulation, all of this will actually enhance the immune system. I think Dr. Manish will be talking a little more detail about this particular effect. Next, let's talk about the impact of physical activity on mental health. So there are several theories as far as physical activity is concerned related to mental health. Not one theory has completely, it's not a proven theory, but we have several hypotheses. The first and foremost is the thermogenic theory. So we all know that when we exercise, there is going to be increase in the body temperature. So when the body temperature increases, especially in certain parts of the brain, like as in the brain stem, it causes relaxation of the skeletal muscles as well as the tension around. So next we come to the endorphin theories. So endorphin theory is the release of beta endorphins is known after a physical activity, which causes reduction of stress. Now this endorphins is also supported by what we know as runner's high, which people experience after a long running episode. The third is monoamine. So there is going to be an increase in the neurotransmitter, which is noted in the plasma urine. So similar increase is expected in the brain as well. So the release of serotonin, dopamine, and norepinephrine can relax our body as well. The fourth is the distraction. Okay, distraction from exercise gives us a distraction from worries and depression. So distraction is often used as a coping strategy, and it has a positive influence in the management of depression. So in fact, it is a much better strategy compared to self-focused or introspective strategy. The next theory is about self-efficacy. So when you are self-efficacy, is just nothing but a belief that one can actually perform and complete a task with confidence, right? The moment a person completes about 1.5 kilometers of walk, he feels good. So that is how self-efficacy works. And finally, nerve growth factor. So with the physical activity, certain nerve growth factors are released. So these nerve growth actually structurally reorganize the brain. So there are theories saying that with the nerve growth factors, the hippocampus, which is a center for mood, actually grows in size, and that helps in dealing with depression and anxiety. Now, next is impact of the physical activity on comorbidities. So we all know that this is a very, we all keep emphasizing physical activity on the levels of comorbidities to our patients time and again. So let me not get into the details of this given the time constraint. So we all know that physical activity reduces the risk of hypertension, stroke, cancer, diabetes, and it improves cardiorespiratory fitness, strengthens the bones, and also improves the sleep pattern. Now, coming to the next, the most important thing, how is it going to help if you are affected with COVID? Okay, here again, just as Dr. Jaspreet has mentioned, I'm not talking about physical activity when there is an active episode of COVID or immediately after COVID. So the impact of, I'm here talking about physical activity before a COVID. So in case a person gets it also, how is regular physical activity going to help the person? The first and foremost is it boosts the immunity. As we all know, it is going to boost the immunity, which can help in fighting the disease. So we talk here, second, we talk about, there are a few things that we keep talking during this pandemic. We talk about ventilators, respiratory failures, multiple organ failures, building immunity, comorbidities, every now and then. So most of these are very well addressed by physical activity. So it has been proven that regular physical long-term activity actually helps in improving the cardiovascular function, maintains the coagulation fibrinolytic homeostasis, as well as maintains the cellular stress. So this coagulation fibrinolytic is very critical because a lot of COVID patients are experiencing stroke-like symptoms because of the coagulation problem. Second, as I told you, it improves the strength of respiratory muscle infection. So a few of the affected individuals are moving into the ventilator, right? So what happens when we have to wean from the ventilator, the strength of the diaphragm and the muscles, respiratory muscles, is very, very critical. So if it is very weak, even before the attack of pandemic, it is very difficult for us to wean. So what it can result is ventilator induced diaphragmatic dysfunction. So this makes the whole process of weaning very, very difficult. Finally, as I told you, it also boosts the immune system. So it is actually, in fact, very highly proved. So immunosense is what, senescence is something experienced by geriatric population. So one study actually on examining about 125 adults have showed that high level of physical activity has helped them increase the B cells and the T cells compared to those without physical activity. So the next important topic, we time and again say the seniors are at higher risk and their risk, so please stay at home, right? So what could be the reasons that we can say that the seniors are at high risk? The first reason is immunosenescence. So immunosenescence is nothing but, as I already told you, it is our immune system going into an aging process. Okay, so people with immunosenescence will have poor control over the initial inflammatory response, as well as the later adaptive immune response is also slightly weak. Okay, this is one of the reasons why seniors are affected. And next, secondly, if you say regular physical inactivity and sedentary behavior, right? So once, as I told you already, the biggest problem is people decide not to move. So which means the sedentary behavior is high and the regular physical inactivity is also high. So this, because of which, what is going to happen is the muscle will go for a wasting and a weakness. And muscle is a very, very important immunoregulatory organ, and it produces a lot of anti-inflammatory and immunoprotective uh, uh, efforts. So these effects are lost because of regular physical inactivity and sedentary behavior. Third, I'm going to talk about the impact of social isolation and confinement. So social isolation would mean there is going to be a decline in the physical activity. So when the physical activity is going to come down, it means the immune system is going to further come down. Plus, it is also going to pose a bigger challenge with the cardiometabolic disorders. Fourthly, we have the presence of comorbidities. So as we age, we are unfortunately blessed with a lot of comorbidities as well. So this comorbidities is already known to have an impact and it reduces the immunity. So this is also another reason. The fifth most important is the age-related changes, wherein we have a weak respiratory muscles, and because of the weak respiratory muscles, the problem the seniors affect, the extent to which the COVID infection happens is also going to vary. So now coming to what is COVID doing to our elders? Okay, so we've shown that 2 weeks of inactivity reduces muscle strength. So we are now in a situation where people are supposed to stay home. So the physical inactivity is on increase, sedentary behavior is increased a lot. There is no physical activity literally happening, especially in elders, because they are given even more serious warning to not step out of the house. So now 2 weeks of inactivity reduces the muscle strength by 8% and accentuates sarcopenia, right? So as we all know, muscle is a very important factor, immunoregulatory organ, and this immunity part is completely lost. The next is less than 1000 to 1500 steps a day actually increases the blood sugar level. So it also, so what happens with less movements, there is going to be an alteration in insulin signaling, resulting in an increase in the peripheral insulin resistance, and it will also going to help insulin sensitivity, plus even the lipid metabolism will be changed. So as a result of which further the comorbidities are also on the rise. The third point is physical inactivity over a week causes immune system dysfunction and thus increasing the infection of susceptibility. So once our immune system is down, we do not have the power to fight against a COVID infection. And that is why the severity of the infection in elders is really even more higher.
Sorry to interrupt, ma'am. We are really running short of time.
Yeah, last slide.
Okay.
So this is a cycle of frailty that we have. So isolation resulting in inactivity, depression, and finally frailty. Okay, so while we all understand that exercise, I mean, we all understand that social isolation and is very important. We also have, if it is before the COVID attack, it is very important that we exercise at an optimal level. So here is the optimal level. Exercise should not be light, it should not be heavy, because there are hypotheses saying there's something called as open wind hypothesis, which says that with heavy exercise intensity, the immune is actually coming down. So next, to conclude, what I would say, to reach a port, we must set sail. Sail, not tie at anchor. Sail, not drift. Franklin Roosevelt. We are all fortunate. We are all, very sadly blessed with this pandemic. And unfortunately, we have to sail through it, and we cannot, just like that, skip it. So let us all be physically active when we are, without a COVID, and when there is a COVID situation, it's important that we rest and revive our symptoms and protect our elders to the greatest extent. Thank you, Bihar Association, for giving me this opportunity.
Thank you so much, Sunanda. So sorry we had to interrupt in between.
No worries.
We'll have this session once again, because we truly need to know more about geriatric, and you have been working into it. So we have to, So it was very well explained that to maintain the physical functions and daily routine of the elderly, the JGS recommendations about 8 points, as we were talking about, that is basically focusing on exercise and nutrition, oral function, and social support. So thanks a lot, Sunan.
You're welcome. Thank you.
Okay, so now today we have with us Dr. Shubha Nagasubramaniam. I think I'm pronouncing your surname correctly today. So she is from, she's a physical therapist from Washington, D.C. So sorry, ma'am, today is Sunday and I made you get up early in the morning. So she'll be taking up ergonomics in musculoskeletal pain during the pandemic. Shubha, ma'am?
Yes, I got it. Thank you, Smita. So my name is Subha, and I'm a physical therapist, and I practice in outpatient physical therapy in Washington, D.C. First of all, let me express my thank you to IAP Bihar and also Smita for organizing this event. And I'm seeing all these awesome presenters is pretty great. Great job, Sunanda. I'm going to go ahead and just jump into the topic and try to make it as concise as possible. First, when I was asked to speak on it, I don't directly work with COVID patients. So I was like, how do I make it relevant and outpatient physical therapy practice so that it relates to a bigger population? One of the things that has united us, sadly, is the pandemic. And all over the world, everybody are facing similar challenges, which kind of shows how small we've become, like a global village. And so one of the things that are, as people talked about the vulnerable population, the direct effects, there are also indirect effects of the people not necessarily affected directly by COVID, but you know, as the workforce is almost forced to work from home, then all these hidden factors come into life, and having musculoskeletal pain makes this very hard as quality of life decreases, and this makes us also prone to being immunocompromised as well. So I'm just going to go over a brief presentation on this. So studies have shown the incidence of musculoskeletal disorders among office workers to be about as high as 40 to 60%. Also, the direct and indirect costs of musculoskeletal disorders as related to work is high, as reported in several countries. The areas of musculoskeletal disorders that have been reported in studies are generally the neck, shoulder, the upper back, the wrist, the hip, and the low back. In fact, as Sunanda made a case for moving, physical inactivity is not only concerning in older or elderly, but also in the younger population, right? People spend a lot of time at their desks, and you know, more than the required 8 hours, we end up spending more than that, and even that is too much. And being sedentary has been described almost as the new smoking. So the new normal. Since the onset of the pandemic, 7 months ago, our whole lives have been thrown into disarray. As physical activity has come down a lot, our movements have been restricted, we are confined to home, and then we are forced to work in less than optimal conditions. So for people, a majority of our white collar workers are working from home, and even with physical therapists, and healthcare providers, a lot of us are doing telemedicine, and we end up, you know, spending some time on the screen. And also workers end up working up, working more time trying to juggle home life and these restricted conditions. The lines of work and home life are getting obscured, leading to lessening in the quality of life. So generally, the role of the pandemic in this current situation. So generally, poor ergonomics has been implicated as a factor in more than one study in musculoskeletal disorders. The pandemic further complicates this picture. There's having to use couches, dining table chairs, you know, people sit everywhere, you know, on the floor or wherever they can find, and they, you know, use a laptop on their laps, or, you know, or when they're sitting on the bed, or, you know, on a table, which is not, you know, is not really a good setup. The laptops, you know, I'm not a great fan of laptops just because the screen and the keyboard are connected pretty, you know, together, and there's very hard to sit in an optimal position with the detachment of, without the detachment of the keyboard and the screen. An additional factor is that daily commute, like, you know, office goers at the very least, even if they are not doing exercising, would be commuting and, or, you know, stepping out for lunch, or stepping to, you know, to the other person's desk. All those even everyday steps have reduced quite a bit, and you know, general movement has been reduced. And there is no break from one position, and, you know, this causes increased spinal loads, you know, poor posture overall. So people end up working more hours at this time, trying to complete their work in the midst of everything. And, you know, since we've been pushed without preparation into this, you know, people become it's even more complicated because people are unprepared, and then so had no means to figure out how a day would look. So what's the support for this? Previously, before the pandemic, there have been many studies which have linked poor ergonomics with musculoskeletal disorders, but the pandemic's unprecedented. So right now, we don't have much data which kind of see what the long-term effects of these kind of positions. If we kind of extrapolate the evidence, it shows us that pretty much that it is not going to be good. But how long-lived are the effects going to be? We don't know that yet. But anecdotally and experientially, I've been seeing a rise in my own practice, and when I've talked to other peers of mine, that there's been a rise in musculoskeletal disorders related to neck, upper back, hips, low back, wrist, etc. But the change in ergonomics is a good factor because of the position adding up over time. There is a cumulative factor that is very important and it's hard to ignore, right? But that alone is not the key. So we have to tackle it in a multifaceted approach. So common issues with setup is using a laptop like this. You can see that if the laptop is on the table, you're forced to hunch over. There's increased kyphosis of the thoracic spine, increased cervical protraction. There's flexed lumbar spine, malposition of the scapulae, increased muscle tension of the epitrapezius leading to headaches. These are common upper body related structures which are stressed because of this position. So the common solution that I offer is investing in an external keyboard and mouse. You can elevate your screen using boxes or like books or anything like that. And you can offer such solutions to your patients. And if they're able to, invest in a keyboard and mouse or something like that, that helps them quite a bit. It helps attachment of screen and keyboard. So the positioning of being able to sit in a much more supported position will help, because you're sitting for not just an hour, but for more than like 6-7 hours. So this helps the screen, so their gaze is between the top third and the middle third of the screen, which is optimal. And then it also, most of the mouse is in front of the screen, and that doesn't help with the scapular positioning, so resulting in shoulder pain, so and the wrist pain. And so if you could move it outward, then that is helpful. So an external mouse. There's not been much support for prophylactic ergonomic mouse, prophylaxis with the ergonomic mouse. It's more so if you did have a carpal tunnel, then it's helpful to have an ergonomic mouse, but in this case, it's not that relevant. But a general mouse, an external mouse would be really helpful. Hip and low back pain, you can definitely see that with the posterior pelvic tilt that's happening with slouching and a low chair, right? The height of the chair, reclining backward, all of this end up creating hip stresses and low back stresses just because of the position of the pelvis. And there's no, anterior tilt does not happen. And so that it worsens it because it takes the spine away from neutral position. So easy solution is sitting with your hips higher than your knees, about 100 degrees. And so that way it promotes neutral spine, making sure there's a light anterior tilt to facilitate neutral spine. Lots of people could do it with an office setup, an office chair. If you're unable to do this, common things that I ask people to do, use pillows or blankets, or you can fold it into a wedge and increase the height of where you're sitting on. That creates that tilt, that anterior tilt of your spine, but also gives you that extra height to help your hips and knees be in a better position. These are some things that you can, encourage your patients to make. While treating musculoskeletal disorders, it's very important, especially at this time, to talk about positioning. And if you offer solutions for telemedicine, this is like an easy enough solution when you can, assess their workplace, help them with different kinds of pain. Does ergonomics solve the issue? Yes, it's one part of the puzzle, but it is not the complete puzzle. It needs more than that, right? It's a multifaceted approach as always. Besides sitting better, doing small exercises at your desk where, you could do like an upper trapezius stretch, or you can ask them to do like, shoulder opening exercises or scapular retractions. All of these are small breaks that people can take throughout the day, which at least takes them away from the same positioning, right?
Excuse me, ma'am.
Yep.
Sorry to interrupt you. Do you have a PPT running on your screen? Because it is not visible for us.
Oh, I don't know why it is not your, I'm sorry. I have a PPT running and I've been, Sorry, guys.
Yes,
Okay.
ma'am, it's visible now.
Sorry. So I'll just quickly show you.
Thank you, thank you.
This is the position I was talking about, and then you can see the common issues with the setup.
Yeah, ma'am. Yeah, if you can put it on the slide share mode.
Slide share mode.
You can press F5, ma'am, from your keyboard.
F5?
Yes. Or you can click on.
Did it happen?
Yes, it happened.
Okay.
Okay, ma'am.
Sorry about that. I wish you had told me earlier. Sorry about this, but this was what I was talking about, the positioning. You can see the protraction and the kyphotic spine, and having like a keyboard set up like this. And there's a lot of products that are easily available, but at this pandemic might be hard, and then you can use like books to separate this, but if you can even invest in a keyboard and mouse. And this is what I was talking about in terms of positioning for the tilt. Okay, so doing, exercises which are like, bilateral external rotations and scapular retraction and upper trapezius. All of this are helpful through the day. So you can tell them to set a timer and do this. So physical activities add on during the pandemic. So brisk walking helps. So maybe in your terrace that you can do, or inside your own house, or which help, to kind of work with the scapulae, right? So opens it up and also helps in the extension of your lumbar spine because you're in a flex position. Then do yoga or Tai Chi or virtual exercises. There seems to be a lot of, interest in that. So whatever suits your needs, you can do chair yoga or like, static yoga positions. All of this are hip openers or lumbar spine openers, or, getting the shoulder to open. These are like things that you can do besides setting up. So ergonomics does play a role in musculoskeletal disorder, but not the only one. Good setup, the desk exercises, active lifestyle, and the other important thing that I encourage people to do, taking periodic breaks throughout the day. So you can set up a timer in any of your apps, any of your smartphones, smartwatches, whatever, and regular 2-hour breaks will help you at least get away from that same positioning, which helps unload and also helps the muscles work in a different way. And these are some things that as physical therapists we should promote that patients should do whenever they see us for a musculoskeletal disorder, and especially during this pandemic. That's all I have. Do you have any questions as well during the Q&A, right?
Thank you so much, ma'am. So sorry.
No worries.
I mean, we had to interrupt in between. So
yes,
now,
I wish you'd done it
quickly
earlier.
we'll call upon Dr. Pallavi. She is a dietitian at Indira Gandhi Institute of Medical Science. So she'll be talking about role of diet in nurturing health during the pandemic. Pallavi, are you there?
Am I audible?
Yes, ma'am, you are.
Okay.
Yeah, Pallavi?
Yes, ma'am.
Yeah, shall we start now?
Yes, ma'am, sure. Good evening, one and all. I am Pallavi. Am I audible, ma'am?
Yes, you are, ma'am.
Okay. Good evening, one and all. I am Pallavi, working as a dietitian in Indira Gandhi Institute of Medical Sciences. Today, I would like to talk about the role of diet in nurturing health during during and post COVID-19.
Ma'am, your screen is not visible.
Okay. Am I visible?
No, ma'am. The screen is yet not visible. It is just showing that you have started sharing the screen.
Okay.
You can stop sharing and start once again, ma'am.
Okay.
Yes, ma'am, we can see you.
Am I visible?
Yes, ma'am. The screen is visible.
Okay. Now, what is a balanced or healthy diet? As we all know that balanced diet is one which contains different types of foods in such quantities and proportions so that the need for calories, protein, minerals, vitamins, and other nutrients is adequately met, and a small provision is made for extra nutrients to withstand short duration of leanness. A balanced diet should provide about around 60 to 70% of total calories from carbohydrate and 10 to 12% from protein and 20 to 25% of total calories from fat. Thus, balanced diet enhances quality of life. And how to achieve balance nutrition through carbohydrate. Unrefined whole cereals, millets, and pulses to meet our daily requirements of carbohydrate and proteins. Always include whole grains like dalia, suji, oats, maize, and how to achieve a balanced protein from the diet. Always use good quality protein sources as it is very important to supply our daily dose of calcium and protein, especially for kids, pregnant ladies, and people who are involved in heavy duty works. The best way to get our essential fatty acids is to include nuts and seeds in our diet. Good quality protein sources are cow's milk and milk products like yogurt, paneer, eggs, lean meat, and fish. Healthy fat sources are rice bran oil, mustard oil, groundnut oil, sesame seed oil, etc. Walnut, almond, dry coconut, sunflower seeds should be included. Now, this is the healthy eating plan. Always use healthy oils and drink water, tea, or coffee with little or no sugar. At least one limit milk or dairy products 1 to 2 serving per day. Uh, the more veggies and the greater the variety, the better. Eat plenty of fruits of all the colors. Eat a variety of whole grains like whole wheat, bread, whole grain pasta, etc. Choose fish, poultry, beans of high biological value protein. To prevent dehydration, drink plenty of water as directed by your qualified dietitian or doctor. Eat foods with high amount of water like fruits and vegetables. Avoid or limit drinks with caffeine like coffee, tea, and soft drinks. Avoid or limit drinks with alcohol. These are the immunity booster nutrients like vitamin C, B6, vitamin A, D, E, These are the immune system boosters. Zinc, vitamin C, iron, vitamin E are the immune boosters that prevent us from various degenerative diseases. As we all know that zinc is important for wound healing. Vitamin C protects cells from oxidative stress, a product of infection or chronic inflammation. Iron aids in non-specific immunity, the body's first line of defense. Vitamin E helps protect cells from oxidative stress. Tomato, basic food to boost immunity that we are using in our daily life. Tomato contains lycopene, an excellent antioxidant that prevent us from various degenerative diseases. Onion is high in sulfur prevents digestive disorders. Ginger and garlic, anti-inflammatory, amazing for gut health. Indian spice box. These improve digestion and have health benefits like anti-inflammatory, antioxidant, analgesics, antibacterial, anti-fungal. Indian spice box loaded with lot of health benefits. I'm skipping this slide. Following mistakes people are making while stocking up, which will damage their immunity and making them more susceptible to infection. Foods that are loaded with refined sugar, like maida and refined wheat flour, aerated drinks, juices, cold drinks, etc. Processed and junk foods, cigarette and liquor should be avoided. Food hygiene or handling during COVID-19. Fruits and vegetables in bucket full of water for 10 to 20 minutes with any one of these like salt, baking soda, white vinegar. Vegetables which you cannot be washed, placed on in sunlight for 2 to 3 days. Hand non-veg products with utmost care. Wash your grocery bags. Products in airtight packets. Wash with soap. Carefully dispose of all the packaging in a separate bin. Wash your hands. These are the healthy recipes, ideas like makhana, murmura, etc. I'm skipping. Check for all the patients at risk of infected with SARS-CoV-19. Check for malnutrition. NRS 2002 system is to detect the presence of undernutrition and the risk of developing undernutrition in the hospital setting. MUST is the 5-step screening tool to identify adults who are malnourished at risk of malnutrition. In step 1, we measure height and weight to get a BMI score. In step 2, note percentage unplanned weight loss. In step 3, establish acute disease effect and score. In step 4, add scores from step 1, 2, and 3 together to obtain overall risk of malnutrition. In step 5, use management guidelines and develop care plan. Individuals at risk or infected with COVID-19 should optimize their nutritional status by indirect calorimetry or by predictive equations. Total energy expenditure of patients greater than 65 years is about 27 kilocalorie per kg body weight. For severely underweight polymorbid patients, it is 30 kilocalorie per kg body weight per day. Protein needs calculated at the rate of 1 gram per kg per day. It is increased in patients with morbid conditions. Fat to carbohydrate energy ratio should be maintained as 30s to 70 for normal, to 50s to 50 for ventilated patients. Regular physical activity in patients in quarantine should continue regular physical activity while taking precautions. Every day, approx 30 minutes exercise or any other physical activity is recommended. Time spent on TV or internet idle sitting should be cut down. Exercise for muscles for muscular strength at least 2 to 3 days a week. Jogging, biking, or swimming for 3 to 5 days a week gives proper workout to heart and lungs. Persons should be physically active every day. oral nutritional supplement to provide at least 400 kilocalorie per day with 30 gram protein is recommended for 1 month. Enteral nutrition is preferable to parenteral nutrition. In intubated patients, in non-intubated ICU patients, oral diet with oral nutrition supplement are the first priority. Adequate assessment of nutrition is recommended to ensure proper calorie protein administration. Intubated ICU patients are fed through nasogastric tube. Patients' energy expenditure is to be properly determined. Hypocaloric nutrition up to 70% of energy expenditure is administered in early phase of acute illness, with 80 to 100% achieved after day 3. During critical illness, 1.3 gram protein per equivalent are delivered. Adjusted body weight for obese persons is calculated as this is the formula of adjusted body weight. That is ideal body weight plus actual body weight minus ideal body weight into 0.33. This is a guideline chart for COVID-19 patients in ICU. Emphasis is on preventing refeeding syndrome, meeting energy and protein needs by starting with low calorie feeding and progressively increasing the enteral and parenteral nutrition intake. Enteral nutrition should be delayed in the presence of uncontrolled shock, life-threatening hypoxemia or acidosis. Low dose enteral nutrition is started in these patients after the early stabilization period. In stabilized patients, even in prone position, enteral nutrition can be started with 30% of measured energy expenditure, increasing gradually up to 100% at day 4. Protein target of 1.3 gram per day is reached by day 5. Enteral omega-3 fatty acids may be added. Blood glucose should be maintained between 6 to 8 mmol per liter. Triglyceride, electrolyte, phosphorus, potassium, magnesium should be regularly monitored. In ICU patient with dysphagia, texture-adapted food is given after extubation. The swallowing disorder is seen up to 21 days in patients. Enteral nutrition or parenteral nutrition may be considered if swallowing is unsafe. What is the impact of nutritional status on elderly and critically ill patients? Prevalence of malnutrition in hospitalized patients is generally high, especially in elderly people. In critically ill patients, malnutrition is independently associated with an increased risk of 28-day mortality. Protein intervention at the right time. Protein receiving 80% of the prescribed target energy have shown lower mortality. Protein requirement of 0.8 gram per day is adequate for all the patients. The mortality of COVID patient is considerable with maximum fatality within 1 to 2 weeks after ICU admission. Age greater than 65.
We are running short. Sorry to interrupt.
Okay, ma'am. Age greater than 65 years, other comorbidities and ARDS are at increased risk. Nutritional status should be evaluated before starting of the general treatment.
Excuse me, Dr. Ma'am.
Yes.
Yes, your
This is the
slide is stuck up, I guess. It is not moving. We are just able to see the same slide. Individuals at risk or infected with SARS-CoV-2. We are still with this slide.
Oh. Am I visible, ma'am?
Ma'am, your slide is the same.
Oh. This is the last slide, ma'am. As Hippocrates says, our food should form the basis of our clinical treatment. Thank you so much.
Thank you so much, Dr. Pallavi. We are running short of time. So sorry to interrupt in between. So now we have a lecture of Dr. Manish, sir. Guruji is available. He had to leave. So sorry, sir. And welcome back, sir. Thanks a lot for joining again.
Thank you, Dr. Smita. Actually, I had another commitment at 7:30, so I had to go in between. So I'm back. I'm done with that job. And thank you very much for making me be a part of this wonderful conference that you and your team have organized. It's a wonderfully conducted program. And God bless you all.
Thank you, sir.
So shall I start, Dr. Smita? Or?
Yes, sir.
Yes, I've just made a very small presentation for you all. I am of this firm belief that we are all learners. COVID is still teaching us lessons every day. And even the best of the experts who have been handling COVID patients, they're all students at the moment rather than being teachers. So it's the little thing which I've just tried to dig in from the past experiences of similar viruses, which again, very briefly share across with you. Because with the COVID, with different thoughts, what should be done, what should not be done, except for the one universal fact that you have to save yourself by social distancing and covering your face and nose, not covering the face, the mouth, and just leaving the nose open is going to serve. I think many people with the masks worn that way, either they believe in science too much that it would be miraculous to save them, or they believe in some magic. That's a different story. Let's go to a little thing about role of exercise in this corona era. So I'm a physio, osteopath, chiropractor. I'm not a chiropractor, but I've learned chiropractics. So this is my little profile. And apart from doing physiotherapy, I've done my doctorate of osteopathy in Spain. And I know you've been glued to your computer for a long time. You've been trying to listen. It's not an easy thing for sitting with the computer. So believe me, I'll make it very, very short. And there is no such remedy which I have to offer to you. कोई ऐसा जादू मैं आपको नहीं दिखाने वाला कि आपने किक की एक्सरसाइज की और आपका कोरोना वायरस भाग गया. ऐसा ना कोई जादू हुआ है ना होगा. सिर्फ हम कुछ चीजों का ध्यान रख सकते हैं. मैंने जैसे बताया ये 2020 का एक जर्नल मुझे मिला जिसमें 20,000 पीपल के ऊपर इन्फ्लुएंजा का बेनिफिट योगा से देखा गया. ऐसे बहुत से जर्नल्स मैंने जब देखे तो उसमें से 3 चीजें मेरे समझ में आई. There are 3 things. First, how to maintain fitness and health in COVID times. Exercise that can boost your chances of fighting coronavirus attack, and exercises for coronavirus patients. So these are 3 important things which exercise can contribute in all the 3 directions. Just a very quick overview. You all must be now very sure how corona is creating trouble. It's not just a respiratory disease. When the virus enters into your body, it triggers an inflammatory cascade. If its number is high, which is called as a viral load being high, and that can affect a variety of your sensory system or a feedback system to your body. And that system does a two-way communication between the virus and your body and can result in various changes which lead to an inflammatory cytokine feedback. Now, this cytokine feedback is very, very devastating. It comes like a storm and it can lead to multi-organ failure. It is not just the adult respiratory distress it can cause, which it was earlier believed that it is a virus which affects only your lungs, but it can lead to multi-organ problems. And this hyper-inflammation system leads to death.
Sorry to interrupt you, sir. We are not able to see on anything on the screen, sir. So could you share the screen, sir?
Sorry. I'm so sorry. It's my fault. I'll just put it again back. And I'm awfully sorry. And thank you for doing that. Thank you for letting me do that. But okay. I thought I had put the screen share. I just clicked it and I left it that way. Yes, yes. Thank you once again, and I'm so sorry for again hijacking some of the valued time. Now, can you see the screen?
Yes, sir.
Thank you very much. So let me go a little more back where we started. So this is the presentation on the role of exercise in Corona era. That's what my intention of the talk today is. This is what I've been trying to learn across the world. Nothing to do with the Corona, of course. Corona stopped my learning. And I'm mainly a manual therapist, an osteopath, as I said, you must be glued to your computer screens and mobiles. So I want to make it short. We cannot do this magic. I talked about this thing. You cannot kick the coronavirus. And so exercise is just to make you stay safe and stay wealthy. I referred some journals. From there, I could come to this conclusion. There's very little on coronavirus, I tell you, but I picked up those journals which were written long back. So one is to maintain fitness and health in this COVID era. Then exercises that boosts your fighting with corona. And the third would be the exercises for corona patients. Sorry, my light has gone off. My inverter is not feeding this room for certain reasons, but of course you can see the slides. This is what happens in corona. The virus infects your respiratory system, and there is some inflammation coming into your system, which triggers certain changes with your dendritic cells, with your monocytes and your macrophages. And this, when happens, leads to a cascade of events, which is, it can cause a two-way inflammatory setup with the things. And they feed your system, and they are, again, depending upon the system, which leads to this kind of cytokine storm. The death and the casualties that happen because of the corona in only less than 2% of the people is because of this cytokine storm. There's a adult respiratory distress syndrome, multi-organ failure, hyperinflammation syndrome is there, which leads to death. So it's not just the respiratory thing, but it's the organ failure which contributes to the death of the patient. Now, we don't have too much evidences how exercise will help exactly in coronavirus. But again, going back on the things like Spanish flu and previous similar episodes of the things like the respiratory similar virus attacks, which were there in the earlier part of the century, we have come to know that if you have a release of extracellular supraoxide dismutase, which occurs during cardiovascular exercise, this extracellular supraoxide dismutase attaches or binds itself to the organs. And that's a very potent antioxidant that prevents the free radicals from damaging to your organs. So if you have been regularly exercising, it's not just आज सुबह उठे एक्सरसाइज कर लिया और हमने सोचा हम कोरोना वायरस के लिए खुद हो गए. अगर आप रेगुलरली एक्सरसाइज कर रहे हैं, तो you can have a cascade of this extracellular superoxide, which could be useful. And then falling back on the various articles that have been presented on the influenza virus, which is very similar to the virus that we are having now attacking our bodies. They have concluded that regular exercise done over a long span of time is having a lot of beneficial effects in preventing the effects of that. And it should be done about 30 minutes a day. And for other animals, they found that for mice, it was 2.5 hours. But for humans, the ideal is about 20 to 45 minutes of exercise per day, about 3 to 5 times a week. Now, I've seen certain people exercising 5 to 6 hours a day. They think their immunity is getting boosted because they're doing extra effort. It is not so. The researchers have shown the vulnerability also is very high in those people who were doing extra exercise. I'm a sports physio, so I can talk about that more at length. बहुत बड़ी गलतफहमी है कि जितनी ज़्यादा एक्सरसाइज करोगे अच्छा है, चाहे वो खाना हो, पानी हो, मेडिसिन हो, एक्सरसाइज हो। एक कंट्रोल्ड वे में जब हम उसको करते हैं, वही हमसे सबसे अच्छा बेनिफिट देता है। तो फुटबॉल प्लेयर्स जो बहुत ज़्यादा एक्सरसाइज करते थे, उनमें भी जो मॉर्बिडिटी पिछले हमारे जो इन्फेक्शंस हुए हैं इस तरह के सिमिलर एडल्ट रेस्पिरेटरी ट्रैक इन्फेक्शंस, उसमें देखा गया कि वो ज़्यादा उनकी भी डेथ हुई। जो बिल्कुल एक्सरसाइज नहीं कर रहे थे वो लोग भी ज़्यादा कंपैरेटिवली मरे, लेकिन सबसे ज़्यादा प्रोटेक्टेड वो थे जो मॉडरेट एक्सरसाइज करते थे। Right. And it could be not just simply running, it could be playing some sports, doing yoga, stretches. That's one thing. So if you want to exercise, do it in moderation, do it regularly. That's the first take-home message I want to talk about. Second, going to the problem where COVID patients, now what should they do? There have been claims, I was going with some YouTube projections, and that was all in papers in England, that certain kind of breathing exercises do save a lot of patients from death from COVID, especially when they have this SpO2 falling down and they have the problem. Yes, if there is no cytokine reaction and you are suffering from some other ailment in your respiratory tract, these exercises are very, very helpful. But cytokine reaction probably will not save you from that. So what are those things? The breathing exercise, which is there in your textbooks. I'm not talking of something new, and not the gentleman doctor from England talked about something new. When I was in BPT second year, I read that breathing exercise with inspiratory hold. What is that? Many times, some part of your lungs are not ventilating. They are cut off because of mucosal plugs or because of some other blockages in the tubes which divide from trachea. Right. So this bronchi or the bronchioles, when they get blocked, a particular portion of the brain is now not getting ventilated. So you're already falling oxygen level because it is creating an effect on your respiratory system. Half of the lung is not working, or 20% is not working, the remaining is not functioning nicely. So you have this problem. So we can activate the 20-30% which is not working, or 50% which is not working, by doing this breathing exercise with inspiratory hold. And that's a very simple thing. What you do, you take a long deep breath, hold it for 3 seconds, then take another bout of breath. सांस लिया, 3 सेकंड रोका, दोबारा सांस लिया। जब आपके एक पर्टिकुलर एरिया जो कि वेंटिलेट कर रहा है, उसमें आपने पूरा उसको सैचुरेट कर दिया है एयर से, नॉट ऑक्सीजन, उसको सैचुरेट कर दिया है, तो वहां पे छोटे छोटे पोर्स ऑफ कॉन्स होते हैं। एक चैनल तो एल्वियोलाई की है जो आपकी ब्रोंक्यूल्स हैं, और दूसरा चैनल है एल्वियोलाई एक दूसरे के साथ छोटे छोटे सुराखों से कनेक्टेड होते हैं, स्मॉल स्मॉल पोर्स, व्हिच वी कॉल द पोर्स ऑफ कॉर्न। अगेन दैट इज देयर इन योर physiology book of BPD first year. So those pores of Corns send some air to that area when you take a second puff. Now these areas start getting stored up with some air, and we have a recoil system in the lungs. We do an active passive breathing, so the air is forced out, breaking that mucosal plug, and that area starts reventilating. Certain people believe prone is a good thing to do ventilation. Why? Because when we are lying on one side, air always travel to the upper side, doesn't go to the lower side. Air is lighter. And there's a what we call as in sports physiology terms, ventilation, the cardiac perfusion ratio getting affected. जो एरिया में ज्यादा खून आता है, जो नीचे वाले हिस्से में होता है, एयर ऊपर आती है, वो रेशियो थोड़ी सी इफेक्ट हो जाती है. तो उसको बैलेंस करने के लिए people say that you can do exercise in prone. So that could be very helpful in people with this kind of problem. And then, once you're recovered from COVID, there is some fibrosis in the lung want to happen because you had an infection. So the breathing exercise has to be carried there and then. So that was little things I wanted to share with you all. Thank you very much for giving me a patient time to listen. And thank you, Smita. Thank you, IAP Women's Cell, Dr. Ruchi is there, and other members. You all have been very strong task force. I wish Smita would have not gone back to Bihar. I would have kept her in my college in Dehradun. The way she's working, she would have been a big asset to us as well.
Thank you so much, sir. Thank you for sharing your knowledge. It was a very informative session, sir. And as usual, you always rocked. So have an objective view of the crisis we are facing. People, for example, staff and patients may look to you as a leader to provide information to help them make decisions and also provide reassurance that we can take care of them at this time of need. Faith is daring to go beyond what the eyes can see. Thank you so much, sir. So, no man or woman needs sympathy because he or she has to work, because he or she has a burden to carry. Far and away, the best prize that life offers is the chance to work hard at work worth doing. It's not the awards and prizes that add value to one's work, it's the work that adds value to the awards and prizes. Well, her actions inspire others to dream more, learn more, do more, and become more. She is a leader. Her innovation distinguishes between a leader and a follower. She doesn't follow where the path may lead. She goes instead where there is no path and leaves a trail. Dr. Ruchi Vashne, ma'am, National Head IAPWC, her true mark of a leader is the willingness to stick with a bold courage of action. Ma'am, please come up.
Thank you, Smita ma'am, for the wonderful introduction once again. Thank you all. Thank you, Manish sir. It is always a pleasure to listen to you, sir, and you always support us. Thank you. Thank you to all the speakers, the entire organizing team. मैं दो बात बोलना चाहती हूँ आज इस कोविकॉन 2020 की ग्रैंड सक्सेस को देख के. स्मिता मैम, आपने एक ड्रीम देखा और उस ड्रीम को फुलफिल करने के लिए पूरी मेहनत की. कई बार आपको लगा कि ये अच्छा नहीं हो रहा, शायद हम नहीं कर पाएंगे. आईएपी विमेन सेल बिहार को आगे लाने के लिए जो आपका एक विजन था, आई थिंक यू आर अ ट्रू लीडर, बिकॉज एक डिफिकल्ट सिचुएशन में इतनी अच्छे से प्लान करके 2 days एक नॉलेज का एक एक्स्ट्रा वेगेंजा रहा सभी लोगों के लिए, सभी स्पीकर्स के लिए, सभी सीनियर्स, एस्टीम्ड पैनलिस्ट के लिए, सभी लोगों के लिए. सिन्हा सर थे, झा सर थे, जोसनी मैम, विनय सर, all the seniors, Reena madam, Purnima, I can see you. So you all have done fantastic. सभी participants को मैं एक ही बात बोलना चाहती हूँ. आज मैम ने मुझे एक ड्यूटी दी है सभी लोगों के जो कॉम्पिटिशन्स हुए थे उसके प्राइजेस अनाउंस करने की. बट बिफोर दैट आई वांट टू से इट इज हाई टाइम लर्न फ्रॉम द पीपल लाइक मनीष सर, लर्न फ्रॉम स्मिता मैम, स्टार्ट गिविंग बैक टू द प्रोफेशन. अब वो टाइम नहीं रहा है जब हम सोचें कि प्रोफेशन ने हमें क्या दिया, एसोसिएशन ने हमें क्या दिया, गवर्नमेंट हमें क्या दे रही है. इट इज द हाई टाइम. कोरोना ने सबको ये सिखा दिया है दैट व्हाटएवर लिटिल यू कैन डू, प्लीज डू इट for the profession, for the society. You know, अब वो पूछने की जरूरत नहीं है हम क्या कर सकते हैं, एक सिंगल आदमी क्या कर सकता है या एक सिंगल विमेन क्या कर सकती है. You have seen that the scenario has changed, people have come up, और individual efforts do count. Because अगर आपको एक छोटी चीज की महत्वता देखनी है तो कभी भी एक बंद कमरे में एक मॉस्किटो के साथ सो के देखिए, then you will understand the importance of that mosquito. So it is, you know, the determination, the will to work. And I truly say that believe in that you can do that. As APJ Kalam sir says, dream big, don't work for winning, work for the success. Because success आपकी है, success किसी को हरा के नहीं मिलती. Success आपको अपने passion से, success आपको अपनी determination से, अपनी dedication से, अपनी decency से मिलती है. And it's like always I say 3S should count. You should always seek the opportunities which comes. Surround yourself with learned people like Jha sir, like Manish sir, Narki sir, Dharam sir, Deepak Kepri sir. They all are the legends. और इन लोगों से आप सीखिए and speak the truth. Speak with honesty. Speak for those unfortunate people जिनको हम लोगों जैसे अभी स्टेज नहीं मिला, हम जैसे लोगों को opportunity मिली, but बहुत सारे लोग अपनी बात कह नहीं पाते. So please speak for them, be their voice. और I think अगर हम सब लोग ऐसा सोच लेंगे कि we have to be successful, not by किसी को हरा कर नहीं, but खुद को आगे लाकर दूसरे profession के लिए काम करके. So that would be the greatest thing that we can give to the profession. Thank you, Smita ma'am, to invite me and tell me when I have to announce the results. So I'll do that.
Thank you so much, ma'am. You don't need to be told. So before announcing, ma'am, at least take a look. The selected candidates presentation, at least. We'll show the posters to you, ma'am. Over to you, Chandni, please.
Yes, ma'am. Let me know if you can see my screen.
Yes, it is visible.
So we have this poster coming in from Surbi.
Surabhi, are you there?
Surbi.
Can we announce, ma'am?
Yes, ma'am, she's there.
Okay, so Surbi, congratulations because of your creativity and innovation. You are the first prize winner of the poster competition. Congratulations.
So I'll just walk you through the PPT, what she has prepared.
Yeah, ma'am, I'm there. Hello, ma'am.
Congratulations. Second.
I'll be sharing my screen again. So we had one paper coming in from Rishmita. So this is poster presented on role of physiotherapists during COVID-19. Rishmita, are you there on call?
She's not there.
Okay.
Ashmita, Smita ma'am, we have to announce along with or?
No, ma'am, you can continue, ma'am.
Yes. Okay, so next is Pragati's poster.
Yes, ma'am. Good evening, everyone.
Pragati, you can share your screen and you can walk through your poster.
You go ahead. Pragati, I think there is some technical fault. We can announce.
Yes, ma'am.
Yes.
Yes, ma'am.
All the participants, you all did fab work, and a lot of innovation from the side of students, physios, and I'll announce the entire results. Surbi is the first prize winner of the poster competition. Pragati is the second prize winner of the poster competition. Congratulations, Pragati. Third
Thank
is,
you.
congratulations. Third is Hashmita for her wonderful innovation. And fourth prize goes to Shruti. Shruti, are you there?
Yes, ma'am.
Congratulations. So you all four sheroes of the future have won the poster competition, and you will be getting the gift vouchers sponsored by IAPWC Bihar through mail or WhatsApp. First prize winner will get 1,000 rupees voucher. Second prize winner will get 800 rupees voucher, and third and fourth prize winners will get 500 each vouchers on their mail or WhatsApp. Right, Smita ma'am? You are our sponsor.
Yes, ma'am. No, ma'am. All of us together. It's a small initiative we have started with.
Okay. So next is dual dance. Ma'am, are you going to show something? Or can we announce?
You can announce, ma'am. We had shown in the morning.
Okay, so we have a duet dance on Lavani performed by BPT final year students Sadhana Raj and Nivedita Sharma. Congratulations, girls. And for the poem competition, the first prize is again, I think, Pragati. Pragati, you've got the for poem first year student IGIMS Patna. And for solo dance, it is Ritika, first year student IGIMS Patna. Congratulations, Ritika, Pragati, Sadhana Raj, and Nivedita. Congratulations, girls. The scientific session was chaired by our respected Josni madam. Josni ma'am, thank you so much.
Thanks a lot. Thank you. Thank you.
Thank you, ma'am. You
And
can say a
thanks
few
for
words,
coming.
ma'am.
Thanks for gracing us this occasion. Thanks a lot.
Thank you, ma'am. Then Abhilasha Sinha ma'am. Abhilasha Sinha ma'am, Sushmita Singh ma'am, and Runjun ma'am. They were our scientific committee. Thank you all. Do we have Abhilasha ma'am, Sushmita ma'am, and Runjun ma'am?
They are there, but they are not in the panelists. So,
okay. Okay, so thank you all. I'll write it down for you all in the message section. Thank you all. And congratulations for organizing this wonderful COVICON and being the part of the organizing committee as scientific chairpersons. And for our cultural committee, we have our very own Dr. Purnima as the cultural committee head, Dr. Angika, Dr. Jyotsna, and our young dynamite, Dr. Aparna. So we all four are there. Purnima, Angika ma'am, Jyotsna ma'am, Aparna ma'am. Thank you very much. Please, Purnima, say a few words.
Thank you, ma'am. I feel happy to be with you in every event. Thank you. Thank you so much.
Thank you to our cultural committee. You did a great work in judging, and I think next time we will have a lot number of more entries, seeing the way you all have judged and decided the winners this time. Thank you so much. Anything else, Smita ma'am?
I'm sure it's yours, ma'am. All yours.
Oh, now I would like to say now organizing secretary should give a Thanksgiving speech.
Well, to all the superwomen I've already told, no. So we know from the viruses that there are regional differences and that the negative effect on the immune systems, on almost all the organs are getting affected. So we know that in this pandemic we have to take care of ourselves. So before ending up, I would like to just call upon to Purnima. She'll be giving vote of thanks, ma'am, to all the team who has worked so hard.
I can see Alpana ma'am. Good evening, ma'am. Sunanda ma'am. Subha ma'am. Monica ma'am. Reena ma'am. Thank you very much. You all have supported very strongly our organizing secretary. That is why they like the event went successful, and the viewership will increase now after the the entire things are over. So YouTube and all, we will promote it as much as possible, so that the entire country should know that IAPWC has Bihar has done this great they have taken this initiative and they have done it with their strong will, because it was very difficult in these difficult circumstances to bring everyone together and to make this garland of jewels of seniors. Thank you so much. Yeah, Punima, over to you.
So cooperative, ma'am. I mean, and they are always there to help us, and they are always ready. I mean, anytime you give him a call, they are, standing behind you. Okay, which kind of help you need? I'm there for you. So unconditional support, which we say, right? So thanks a lot to full team, ma'am. So now
I
over
know,
to you. Yeah, over
I know
to you.
you call at 12 in the night also when you are
Yeah,
working.
I disturbed.
Yeah, Punima, please.
Thank you, ma'am. परम आदरणीय मुख्य संरक्षक प्रेसिडेंट ऑफ आईएपी माननीय डॉक्टर संजीव कुमार झा सर, आदरणीय संरक्षक प्रेसिडेंट आईएपी बिहार ब्रांच डॉक्टर नरेंद्र कुमार सिन्हा सर, सह संरक्षक डॉक्टर विनय पांडे सर, डॉक्टर उमाशंकर सिन्हा सर, इस कार्यक्रम के अध्यक्ष व ट्रेजरर ऑफ आईएपी एंड लॉ महिला आदरणीय डॉक्टर रुचि वार्ष्णेय मैम, सह अध्यक्ष व जोनल हेड आईएपी वुमेन ईस्ट जोन डॉक्टर रीना श्रीवास्तव मैम, आयोजन सचिव व स्टेट हेड आईपी वुमेन सेल बिहार ब्रांच डॉक्टर स्मिता सिंह मैम, मैं आप सभी का आभार व्यक्त करती हूँ कि आप सभी ने मुझे धन्यवाद ज्ञापन का कार्य सौंपा। इस विश्व स्तरीय कोरोना महामारी के बीच आईपी वुमेन सेल बिहार ब्रांच द्वारा वर्चुअल प्लेटफॉर्म पे 2 दिवसीय कोविकॉन 2020 का आयोजन किया गया, जिसमें विभिन्न चिकित्सा पद्धति से जुड़े चिकित्सक गणों ने हमारे बीच अपने अनुभव साझा किए व अपने ज्ञान के प्रकाश से हमें अभिभूत किया। हमारे बीच हमारे अतिथि वक्ता डॉक्टर डोना मैम ने अपना बहुमूल्य समय देकर इस कार्यक्रम को सम्मानित किया। अन्य वक्ता डॉक्टर नागेश अमंगम, डॉक्टर अपना डोंगरे, डॉक्टर मोनिका श्रीवास्तव मैम, आचार्य मानस रंजन जी, नित्य विकास शंकर जी, डॉक्टर शैलेश कुमार जी, डॉक्टर शानी हंसपाल जी, डॉक्टर शब्द फैजल जी, डॉक्टर रीना श्रीवास्तव मैम, डॉक्टर जोशनी खां मैम, डॉक्टर जसप्रीत कौर गंग मैम, डॉक्टर राजीव प्रसाद जी, डॉक्टर सुनंदा संपत जी, डॉक्टर काशी विजयलक्ष्मी मैम, डॉक्टर शुभा नागा सुब्रमण्यम मैम, डॉक्टर मनीष अरोरा सर, डॉक्टर पल्लवी सिंह, डॉक्टर अनुजा भारती, आप सभी ने इस कोरोना महामारी से जुड़े विभिन्न पहलुओं पर ज्ञानवर्धक चर्चा की। शायद ही कोई पहलू छूटा रह गया हो इस महामारी से जुड़े तथ्यों पर जो इस अधिवेशन में चर्चा ना की गई हो। फिर वो सुरक्षा या बचाव, योग की हो या रोग की विभिन्न चरणों की चिकित्सा पद्धति की, खान पान के महत्व या भौतिक चिकित्सा के आयाम, उपचार हो या पुनर्वास, आप सभी का बहुत बहुत आभार कि आपने हर एक बिंदुओं पर चर्चा कर हम सभी का मार्गदर्शन किया। हमसे जुड़े सभी चिकित्सक गण व विद्यार्थी गण एवं प्रतिभागी गण जो जूम, फेसबुक, इंस्टाग्राम और यूट्यूब से हमसे जुड़े रहे, आप सभी का धन्यवाद। उम्मीद करती हूँ कि आप सभी ने इस अधिवेशन से कुछ सीखा होगा व लाभ उठाया होगा। इस आयोजन को सफल बनाने के लिए आयोजन के कार्य समिति व आयोजक समिति सदस्य, आप सभी का साधुवाद। विशेषकर धन्यवाद दूंगी डॉक्टर स्मिता सिंह मैम का, जिनके कठिन प्रयासरत रहने से आईएपी वुमेन सेल बिहार ब्रांच नित नए आयाम को छू रहा है। उन्होंने इस तरह की अधिवेशन एवं कार्यशालाएं आयोजित की हैं, जो एक हमारे भौतिक चिकित्सा के अंदर एक नया ही आयाम है। इस वर्चुअल प्लेटफॉर्म पर कार्यक्रम को सफल बनाने के लिए हमारी टेक्निकल टीम, आईएपी मेन ब्रांच डॉक्टर हिमांद्री मैम एंड मिस चांदनी मैम, आपका कार्यभार बहुत ही महत्वपूर्ण रहा। आप दोनों का भी बहुत बहुत धन्यवाद। आप सभी स्वस्थ रहें, सकारात्मक रहें और अपना अपना योगदान जन जीवन को देते रहें। इसी शुभकामनाओं के साथ मैं अपने शब्दों को पूर्ण विराम देती हूँ। नमस्कार।
थैंक यू सो मच पूर्णिमा, थैंक यू सो मच। इतनी मतलब अच्छी हिंदी, पता नहीं, हिंदी में मैं बहुत कमजोर हूँ यार। स्कूल में भी बहुत कम नंबर आते थे, सो सॉरी। So at the end of the day, the goals are simple: safety and security. The safe of the people shall be the highest law. Well, nothing is of greater importance than the conservation of human life. So there is no I in teamwork. At last, I would like to mention this. So simply stand, it is less me and more we. Teamwork divides the task and doubles the success. Coming together is beginning, keeping together is progress, and working together is success. So with that, we come to the end. Well, we'll say this is a new beginning. So we'll meet again soon. Till then, be informed, be prepared, be smart, be safe, and be ready to fight COVID-19. Thank you so much.
Thank you.
Thank you.
Thank you,
everyone.
ma'am.
Thank you.
Good evening, dear physios, respected seniors, and my dear friends. Today, 4th October, marks the end of day 2 of COVICON 2020, a clinical rehabilitation new normal on COVID-19 e-conference. I, Dr. Neha Singh Mandade, on behalf of IAP Digital team, would like to express my thanks to the organizers of this e-conference, the entire IAP WC Bihar team. You deserve the most profound congratulations and thanks for the excellent organization and spirit of the meeting. I would particularly like to thank our IAP President, Dr. Sanjeev Jha Sir, IAP Women's Cell National Head, Dr. Ruchi Varshni Ma'am, for their untiring energy and motivation throughout this event. Heartfelt thank you to all the eminent speakers and resource persons for sharing their knowledge. COVICON 2020 has loaded us with variety of learnings through the scientific sessions and also gave us opportunity to the young budding physio students for showcasing their talent on this platform. So thank you one and all for your valuable time for this event. Indeed, it was a special one. Thank you.
Thank you, digital team. Thank you, Neha. Thank you, Chandni and Abhishek, Himandri, all the people behind the scenes for making this successful. It was actually, we were all scared whether this conference we would be able to manage. But you all did fab, you all did fantastic. Thank you to the digital team of IAP India once again.
Thank you, ma'am.
Thank you so much, ma'am.
Thank you, ma'am.